કઈ
ટીવી
શું માથું નીચે નહીં કોઈ પગ પડે કોનો
પગ પડ્યું લાગે જોઈ લો તું બી
ए देख तो क्या बोल रहे हो? ये आ गया सिग्नल। ऑडियो केबल कहाँ है इसका? ईपी क्या से? होगी नहीं। कहाँ सोया कहाँ?
થોડી નાખી
हाँ?
ટીવી
हाँ।
નાખી ત્યાં આગળ
गई गई तू बात कर रही है? पति क्यों टाइमर है? पति क्यों जो तो यहाँ केबल क्या मुझे ऑडियो केबल ऐसा है स्पेशल हो गया हाँ डाला है कितना डाला
हेलो 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 આવી ગયો
मैं वहाँ जाके चेक कर लेता हूँ या तो तू जो तो आयु सिग्नल हाँ
Testing. Hello. Check.
Good afternoon, everybody. Welcome to this arthritis imaging update session. This is Hall B. We just bifurcated. So if you were planning to be in some other hall, I just wanted to let you know this is Hall B. We are dealing with arthritis. Sorry, I didn't wait for the chair session. So there you go. Welcome. Yes. So I think what we will do is we will start the session. It's for 2 hours. I will be the moderator and the chairpersons are here. I'm moderating along with you. The first person to talk is Dr. Ali Gurmezi, and he will be speaking on imaging biomarkers for precision medicine in inflammatory arthritis. Dr. Ali Gurmezi has got an extensive list of achievements, most prominently being editor-in-chief of Skeletal Radiology, formerly deputy editor of radiology, and he has over 770 papers and 500 invited lectures in 80 countries. He is a very established musculoskeletal radiologist, and everything he says, please listen very carefully and note. These are important teaching material that you are not going to get elsewhere. Thank you, Dr. Ali.
Oh, okay. Thank you. Sorry, I had to push the button. For radiologists, it's a little bit difficult sometimes to push a button. So thank you very much for the introduction, and thank you for the invitation. What I am going to do right now, if you listen to Christine Chang talking about phenotyping, I am going actually to talk to you about one of the imaging phenotype, which is the inflammatory one. That's actually my conflict of interest. We are going to go through a technical aspect, non-contrast enhanced MRI versus contrast enhanced MRI. We're talking about MRI versus histology, synovitis and structure, the relationship, synovitis and symptoms. And then we are going to talk about new MRI techniques, other modalities, and we conclude. Now, Christine showed a little bit, actually, I think, one of the papers that described the phenotyping. That actually really came later. The first person to talk about phenotyping, as you can see, it's in Lancet, so really very, very important journal, one of the best on earth, is Blisma, Janssen Blisma from Netherlands, where he actually talked about the post-traumatic, acute or repetitive, metabolic, aging, genetic, and pain. I came later, 2 years later, where I described in arthritis and rheumatology the phenotyping from the imaging perspective, where we could add, we don't have slides anymore. Yes, where we talked about actually, of course, what we see on imaging, meaning synovitic or inflammatory, osseous bone, marrow lesion, and the osteochondral bone relationship. Meniscal cartilaginous, that's the one we call actually mechanical. Ligamentous, atrophic, hypertrophic OA. I'm not going to go through all these phenotypes that we describe in imaging, but know that just as a matter of fact, because you were introduced to the area of phenotyping, today there are more than 1,100 phenotypes in osteoarthritis. For example, there are groups in New Zealand and in Australia talking about phenotyping smoking versus non-smoking. That's another phenotype. For example, just as a matter of fact, that way I saw actually, just recently. So from the imaging perspective, we have around 7 to 8 phenotype that we can see in imaging. Now, from the inflammatory that I'm going to talk about today, or right now in front of you, know that every single person who has an advanced OA is going to have some inflammatory. But I am going to talk to you about the inflammatory phenotype from the early stage. So really something driven by inflammatory phenotype, okay? Very early in the disease. And you may ask me, when we can see inflammatory actually disease in a way. We can see it as calculon 0, meaning without any radiographic osteoarthritis feature. You can see inflammatory disease which is related to OA, osteoarthritis. By the way, one thing which is extremely important, you don't need, for a definition of osteoarthritis, you don't need an X-ray. If you look at the ACR, American College of Rheumatology definition, is pain and stiffness for the last 30 days. And where actually the X-ray will come is for confirmation. So you don't need it. Rheumatologists, they don't need as to know this is inflammatory or this is mechanical osteoarthritis because they have that definition per se by the ACR, American College of Rheumatology. Now, we are going to talk about T1 weighted, as a sequence. Of course, all water sensitive sequence TER are for density or intermediate or T2. We're going to talk a little bit about contrast enhanced MRI, of course, and then we're going to talk about novel non-contrast images because we want actually to not have actually contrast images, and we will see it's still limited at this point, and we talk about DC-MRI or dynamic contrast enhanced MRI. But let's start with the non-contrast MRI. So we wrote in 2009 these papers that is comparing all these sequences, T1 and T2 especially, but we realized that because we don't have any idea how to differentiate the synovitis inflammatory tissue from actually the joint effusion, we have to call them per se a Hoffa synovitis, which is a surrogate marker of synovitis, but that actually hyperintensity within the Hoffa fat pad. I don't know if you see it. Yes, it's here. That Hoffa fat pad, this, for example, can be considered as severe Hoffa synovitis or grade 3. And here we talk about effusion synovitis, and why we said effusion synovitis, because we have absolutely no mean or no possibility to differentiate the joint effusion from anything which is an enhancement, nodular enhancement, or regular enhancement, or irregular enhancement of the synovial membrane. Now, this is actually what we found out. We compared 50 patients, and we took the contrast-enhanced MRI as a gold standard, and we compared those to the proton density in fat-saturated sequences. What we found out is Hoffa fat pad signal alteration has a low specificity, which is around 10 to 38%, depending on actually really the paper that you see. For ours, it was 23%, and quite okay, accepted sensitivity around 70%, all right? So what we concluded there is that signal of Hoffa fat pad on non-contrast enhanced MRI do not always represent synovitis, but are non-specific, albeit sensitive, all right? And the scoring, the semi-quantitative analysis is better to be done with contrast enhanced MRI. Now, if you ask the question from the literature, non-contrast enhanced MRI versus contrast enhanced MRI to look at any inflammatory disease in the knee or elsewhere, but most of the work was done on the knee, is non-contrast enhanced MRI sufficient for imaging assessment of synovitis in the clinics or clinical trial? The answer is no. Why? Because non-contrast enhanced MRI is non-specific, as we said, cannot differentiate between synovitis and effusion, and is inconsistent association. It has inconsistent association with pain by different studies. So that's why I thought about actually, okay, so then if we have actually non-specificity here and sensitivity which is low, let's actually get something that is comprehensive, that is semi-quantitative, that we can do in actually the clinic or in any clinical trial, and we call this the 11-point synovitis. Now, I'm not going to describe, all actually the location, just sufficient to know that there is anterior location and posterior location. A previous scoring system that we developed also in Boston at Boston University by Bakers et al. And I'm co-author, it has only actually 4 sites within or around actually the patellofemoral joint. That's not really the whole or the holistic approach to look at synovitis within the knee. It has more than those, location around actually the patellofemoral joint. Now, each of the location will be graded 0, 1, 2. 0 is normal, 1 is 2 to 4 millimeter of thickness of the membrane, and 4 or more, it's actually a 2. When you add them all together from 11 location, you'll end up having a score from 0 to 22. And this is what we classify this by thresholding on actually, of course, statistical analysis. no synovitis when you have 0 to 4, mild synovitis 5 to 8, and then moderate synovitis 9 to 12, and more than 13, it's severe, or greater than 13 is severe synovitis. Now, when we look at this, we have an intra-reader, which is okay, as you can see, from good to perfect. And most importantly, when we look at the WOMAC pain score, and we did the analysis, we showed that moderate severe synovitis showed significant association with maximum WOMAC score, pain score item compared to knee with no or equivocal synovitis. Now, we took actually this to another level where we checked on, again, the diagnostic performance of Hoffa pad compared to the contrast-enhanced MRI. And again, non-contrast-enhanced MRI showed a sensitivity which is around 71% for infrapatellar, meaning the region which is really below the patella. If you go intercondylar, it gets better, 88%. But again, the specificity is really low. And again, because we're comparing non-contrast to contrast, contrast-enhanced MRI identify association with pain better than non-contrast-enhanced MRI. We looked also at what is better. Is it Hoffa synovitis or effusion synovitis? Because most of us will think that the better surrogate is the Hoffa synovitis. But what we find out is that effusion synovitis showed superior correlation and sensitivity than Hoffa synovitis. So if you want to understand if the patient on non-contrast-enhanced MRI has synovitis or not, and you don't have the contrast-enhanced MRI, look at effusion synovitis better than on Hoffa synovitis. And here the demonstration. This is the patient on the upper row here, is pre-contrast, and this is post-contrast. And as you can see, if we take the non-contrast enhanced MRI, this patient has a joint effusion graded 2. So we grade effusion from 0 to 3. We grade actually the Hoffa fat pad from 0 to 3. If we add them together, is 0 the minimum, 6 the maximum. 0 to 2 would be actually a mild synovitis, all right? Moderate is from 3 to 4, and 5 to 6 is severe synovitis. So per se, this patient has a score of 2. When you go for a contrast-enhanced MRI, if you remember, minimum of synovitis has to be between 5 and 8, all right? When you look at the patient, you see here, there is a views enhancement. This is more than 2, this is more than 2, that's more than 2, and it goes on and on, even posterior to lateral meniscus. In fact, this patient, when you do a semi-quantitative analysis with contrast-enhanced MRI, has a 14. So this patient on non-contrast-enhanced MRI has minor or mild synovitis, but the reality when you contrast it has a severe synovitis. And this is what we are talking about. You have a really non-specificity when you do a non-contrast enhanced MRI. No one of us will think that this patient will have so much synovitis at this point when contrast enhanced MRI. Now, when you look at that histology, I do think the best paper ever written is by Damien Loyal from Nancy, France. When you look at this patient and look at the semi-quantitative assessment on non-contrast enhanced MRI and contrast enhanced MRI, and he wanted to prove histologically what's in there. And what happened, if you look again at this patient, here a non-contrast enhanced MRI, and this is the contrast. You see how no one can actually imagine that, I can tell you this patient didn't enhance at all, or will be enhancing something that you don't know, you don't actually, evidently you don't actually imagine. But what happened here is this patient has a huge amount of nodular enhancement on contrast enhanced MRI. And when you look at this image, you have a big nodule here in front of another big nodule, so they are like kissing each other, and these are actually the nodule on histology. So really representing exactly, almost mirroring exactly the image on contrast enhanced MRI, you have there the histology. And that's why they concluded that the best way to do an synovitis assessment would be with contrast enhanced MRI. It's the closest to be to histology. Now, recently we've done this meta-analysis where we wanted to know what is actually the best way, again, just to make sure that not only us seeing this, but other people as well. There is not really much there. I think we collected more around 12 studies that have this histological confirmation. And what we concluded here is the static and dynamic contrast enhanced MRI evaluation of knee for synovitis, positively correlate with macroscopic and microscopic feature of synovial membrane inflammation. So again, really this is to show that if you want to best quantify synovitis in osteoarthritis, you need to have a contrast-enhanced MRI. Now, from the synovitis and pre-OA, that's what I said before. Pre-OA is based on radiographic OA. In fact, rheumatologists, they don't need us for the diagnosis. It's an ACR, American College of Rheumatology definition. But let's say when you look at the X-ray and you say Coagulation Lawrence 0 and 1 are pre-radiographic and Coagulation Lawrence 2 and above is radiographic osteoarthritis. What we've done here is we took from Osteoarthritis Initiative 133 knee with no radiographic osteoarthritis and exactly the same number with radiographic osteoarthritis. And we have actually 4 years of observation. And what we found out is that the effusion synovitis and Hoffa synovitis strongly predicted the development of incident radiographic osteoarthritis. In another word, if you have synovitis right now, go treat it, because if you don't treat it in 4 years, you are going to have most probably an osteoarthritis radiographic that is going to happen. That's what it is. This is not the first study, of course, but this has actually the I think the advantage to show this on really a long-standing Osteoarthritis Initiative trial. And from the anatomical distribution, I wanted to say this to my colleagues that do ultrasound. It's problematic because when you do ultrasound to look at synovitis in general, you look at either in the hand, that's peripheral, it's absolutely fine. But let's see for the knee, what you're going to look at is only around the patellofemoral joint. You don't go profound or deep actually in the joint. In fact, 69% of the the location, the most important location or first location to be with the synovitis is posterior to the posterior cruciate ligament. That's actually so deep that most of the time you don't see on ultrasound, especially in obese patients, and that's what you have when you have osteoarthritis in general. Now, that's actually one of the case where we have a contrast-enhanced MRI, this patient before contrast, after contrast, as you can see. So yes, this patient has some effusion synovitis and some enhancement peripatellar here, but maximum of synovitis, and as you can see in the posterior to the posterior cruciate ligament. So clearly 69% that we saw in this study of 320 patients from video study from Oxford University in UK, that they have, after contrast enhanced MRI, they have actually location in the posterior to the PCL. Now, synovitis with contrast-enhanced MRI can be target, of course, of treatment. For this study that was done in Manchester, UK, they took 120 patients with painful knee osteoarthritis before and after intra-articular steroid injection. And after they injected this and they've done contrast-enhanced MRI in synovial tissue volume, they concluded that synovitis has a potential for treatment because it shrinks after steroid injection, and it can, of course, rebound after that when pain actually recur or relapse. So clearly, you can see the relationship with pain, and you can see a relationship with what happened in contrast-enhanced MRI from the synovitis inflammation perspective. Now, there is another 1 point or 2 points that I'm going to talk about. The first one, which is extremely important. And let's go back to RA, because that's something that I think James is going to talk about. When you have RA, you have, of course, inflammation, and that inflammation should be everywhere, in the hand, for example, or the food or whatever. But the notion of this patchy synovitis is only in the osteoarthritis, and I'm going to just ask anybody who can just tell me, where do you expect to have contrast-enhanced MRI in this patient? The question cannot be answered because we don't know. And in fact, in the same patient, you see here that there is a huge synovitis, severe synovitis after contrast-enhanced MRI, while actually this popliteal cyst, which is evagination of the synovium, as you know, it's continuous with the joint, there is absolutely no enhancement at all. And that's what happened all the time. I see it all the time. All right, I'm doing right now more than 12 clinical trials when I see hundreds of patients almost every week. They come actually to our attention before contrast and after contrast. And I try myself to be tested, and I get actually, of course, almost wrong all the time because of the patchy synovitis. So remember, in osteoarthritis, there can be actually one location where you have contrast enhancement and synovitis, and all other subregions they don't have. Actually, that's why there is another paper. I'm not presenting it right now, but it's still actually a small population, a small cohort. We're repeating actually this on 400 patients. What we found out, correlation with pain with synovitis, it has to be at least in 3 locations on 11-point synovitis. If you have only 1 or 2 locations, in general, you don't have pain. Now, you can see here with this contrast-enhanced MRI before treatment, you see enhancement everywhere almost, and grade 2. This patient has a 16 as score, so it's severe synovitis. And here, 3 months later, you see a complete response. This is actually a stem cell therapy. I'm not going to say the name, so I don't contribute to conflict of interest here. But this is actually ongoing trial right now I'm doing, and you see the treatment got actually absolutely fine with this patient 3 weeks later. You may see that this patient is very early in the disease from osteoarthritis. There is really not much of osteophyte, a little bit of cartilage loss, no actually bone marrow edema, etc. So really early in the disease, and that's how I see it myself. I see a very good response with patients that are early in the disease compared to patients which are evolving in the disease or actually late in the disease. Okay, DCMRI, I'm going to go very fast here because I don't have time. DCMRI is very important. I do think when you want to just have a better response actually to therapy, and especially earlier, like 6 weeks or maybe even 3 to 4 weeks after treatment, dynamic contrast enhanced MRI can give you actually a better response than a contrast enhanced MRI, all right, which can be late. The K-trans, which is of course here a marker of permeability of the vessels, is showing the best performance when compared to other characteristic from DCMRI. Now, flare is one of actually the sequences that we can do right now without injecting gadolinium. The problem of this is, or all of the non-contrast enhanced MRI that we're doing from MRI technique perspective, they underestimate, all of them, they underestimate the inflammation and nodularity. This is a case, as you can see here, of pre-injection, of contrast-enhanced MRI, and you see here the flare. The flare is showing really very regular line, but very thin, while the contrast-enhanced MRI is showing a little bit more, of course, as you can see, nodularity and inflammation. The same thing for diffusion tensor, even though the fractional anisotropy is actually the best way. But again, if you look at the contrast-enhanced MRI compared to the fractional anisotropy, you see that is underestimating the thickness of the synovium. I will finish with the QDES. Again, it's able to show actually the synovitis, but again, it is underestimating. This is the contrast-enhanced MRI. There is a nodule here that you don't see here on the flare. There is a very big nodule here in the patellar pouch, and you see it, or you see it a little bit there. All right, I'm called actually to finish. All right, Doppler, I do think you know the problems. It's difficult to do a deep Doppler assessment. And now with nuclear medicine or PET, it's a good actually alternative, but okay, again, it's a little bit, of course, going further with a very, I will say, costly exam just for seeing a synovitis. But some of the study are doing this and using this for clinical trials perspective. In summary, synovitis can be evaluated with non-contrast enhanced MRI, as I said, but Hoffa synovitis is sensitive but non-specific. All right, novel technique are promising, but still they underestimate synovial thickening and nodularity of synovitis. Contrast-enhanced MRI enables, as I showed, accurate assessment of synovitis and is differentiation between synovium and effusion. Contrast-enhanced MRI synovitis should be recommended because it's has consistent association with pain and WOMAC, as I said, a reliable measure of synovitis, and finally useful as a marker for therapy response, as I showed. And when it comes to MRI in the clinic versus ultrasound, ultrasound is good for rapid triage, when you do Doppler and you see some activity, something that you can do, but you cannot consistently do, of course, a comparison based on ultrasound, as you know. So really, MRI is there for inclusion, exclusion, of course, when eligibility, and finally for efficacy. Thank you so much. And I'm sorry for going a little bit beyond my time.
Thank you. Thank you so much, Dr. Ali Gurmezi. That was excellent. It actually opens up our thought process in terms of how we view osteoarthritis, which is not a non-inflammatory process. So moving on, the person, whoever is ringing the bell, if you can ring less number of times, it'll be okay. Once 2 minutes before, and once they're just done, that's okay. People will get that. Thank you. I now call upon Dr. James Griffiths on the stadium. Dr. James Griffiths is a professor and chairman at the Chinese University of Hong Kong, and his area is all aspects of musculoskeletal imaging. He has produced over 382 full peer-reviewed papers. He is a past president of AMS and past chairman of the Global Regional Outreach Program of the ISS. Today he's going to talk about rheumatoid arthritis imaging, current updates, and emerging techniques. Thank you, Dr.
Thank you, Girish. And okay, let's crack on to rheumatoid arthritis. Now, of course, you know that rheumatoid arthritis is a disease of inflammation of the synovium, the tenosynovium, and also the bone, and this leads to structural damage with erosions and joint space narrowing. Making an early diagnosis of rheumatoid arthritis is very important because it's the most responsive to treatment during the early years. So this is known as early RA. So we need to diagnose the disease early. Similar to osteoarthritis, the rheumatologists don't need any imaging to make a diagnosis of rheumatoid arthritis. They look at the serology, they look at the clinical picture, and they put all of these into an algorithm and into an online app, RheumaHelp, and that tells them the probability that the patient has got rheumatoid arthritis. It's not surprising that radiographs are not it's not surprising that radiographs are not more utilized because they're not really sensitive to detecting early erosions. I mean, you can't see erosions very clearly on this radiograph, but here you can see on MRI, you can see the erosions very clearly in the same patient, same day. Again, here you cannot see erosions very clearly on this particular radiograph. There's moderate osteopenia, but look at the amount of erosions present on MRI on the same day. Ultrasound, of course, is excellent at detecting synovitis and tenosynovitis, but it's relatively insensitive at showing erosions, and it cannot quantify accurately the synovitis and cannot detect bone marrow edema. The sort of ability of ultrasound, the game is changing with the evolution of microvascular flow imaging, which shows synovial hyperemia much more clearly. This is color flow imaging of the wrist, and then you can see with microvascular flow imaging in the same patient marked, hyperemia of the synovium you couldn't see on standard color flow imaging. So it is changing the game in that respect, but still ultrasound is limited in its assessment, although it's very useful. MRI, on the other hand, can exquisitely show all of the inflammatory changes and the structural changes of rheumatoid arthritis, but it's still relatively underutilized in the assessment or follow-up of rheumatoid arthritis, even though it shows all of the inflammatory changes and structural changes beautifully. There are different protocols that people use for evaluating rheumatoid arthritis. These haven't been standardized. Some people scan the foot, and you can see synovitis there, and you can also see intermetatarsal bursitis, which is very common in rheumatoid arthritis, and submetatarsal bursitis, which tends to be less common, but tends to be quite specific for rheumatoid arthritis. But it's uncommon to scan the foot in people with rheumatoid arthritis, not indicated. You can do whole body MRI, in which you do T2 fat saturated sequence of the whole spine and the sacroiliac joints, and post-contrast imaging then of the peripheral joints. And so you can scan the whole body in less than 20 minutes. enabling all of the inflammatory and sites and inflammatory burden to be identified at one go in a very short time. You can also use, by using gradient echo 3D flash imaging, you can produce pseudo-CT images which allow the delineation of erosions and distinction of erosions from subcortical ganglia more clearly. You can also include this imaging sequence. What we tend to use is just very basic imaging, T1 weighted coronal imaging, T2 weighted fat saturated imaging to show osteitis, and then T1 axial post-contrast imaging to show synovial and tenosynovial proliferation. But do we need contrast? Getting into this argument again. For the wrist, honestly, I know Dr. Garmazi was telling us about that we do need contrast in the knee, because the knee normally has a large amount of fluid. In the wrist, the synovial proliferation is usually predominantly synovial proliferation with very little fluid in the wrist region. And by giving contrast, of course, that adds time, it's uncomfortable, and there are some known problems, of course, with gadolinium retention. So if we can get away without contrast, that would be better. And it's been shown that proton density fat-saturated sequences can provide image quality very comparable to T1 fat-saturated imaging in the wrist region, better than T2 fat-saturated imaging. Again, here you can see the synovitis seen on post-contrast imaging of the wrist. You can see the PD fat-sat compares very favorably for that, looking at synovitis, much better than T2 fat-saturated sequences. And again, when you want to look for tenosynovitis here, normally and around the wrist region, tenosynovitis doesn't show very well on post-contrast T1 weighted sequences because the enhancement is quite low. And actually you can see that synovial enhancement more clearly with PD fat-saturated sequences and T2 fat-saturated sequences. So I think PD fat-saturated imaging can reasonably replace T1 fat-saturated imaging for assessment of synovitis in the wrist region. Now, of course, when you're looking at rheumatoid arthritis, you have to evaluate the inflammatory component as well as the structural component and report on these. But the level of inflammation is by far the most important information you can give to the clinician, because the clinician is interested in how much inflammation, how much active synovitis there is. They're not really too worried about the level of structural damage, because generally structural damage is irreversible. And in early rheumatoid arthritis, the most common pattern you see is a combination of synovitis and tenosynovitis. Sometimes you may just get synovitis alone, and sometimes less commonly you may get tenosynovitis alone. So all patterns can be seen. Generally, in everyday practice, we just grade this synovitis as minimal to mild, etc., severe, and this is perfectly adequate for everyday clinical practice. But nowadays, you can actively segment out the enhancing synovium, so you can, instead of saying mild, moderate, severe, you can actually give the measurement of the synovium, provide an actual measurement of the synovium in 22 millimeter. So it's a much more objective measurement of synovial volume rather than just saying mild, moderate, severe. And you can see how this would be useful for comparing different studies, and it would also be very useful for following the patient up afterwards when you can provide an absolute objective measure of the amount of synovium present. That can be done in less than 1 minute following your examination. Also, with respect to bone marrow edema, this can also be now actively quantified by looking at the number of pixels. You can first segment out the wrist bones, and then you can see which number of pixels are of higher intensity in the baseline value. And then you can not only say, give the amount of osteitis present, but you can also look at the intensity of that osteitis. So for example, here you can see that you could get a printout like this, where you can get the percentage of the overall wrist which is involved with bone marrow edema, and also the intensity of that bone marrow edema. And that can also be done in less than 1 minute. So again, it's a very much more objective measure rather than just saying mild, moderate, or severe bone marrow edema. What about the predictive value of MRI? Can MRI predict what's going to happen to the patient down the line? And generally, MRI or imaging was thought to be non-predictive of outcome in MRI, but a study has been performed of 81 patients who had baseline MRI. The patients were followed up at 1 year, and they were followed up again at 8 years, and the identical study was done at each occasion. And the study showed that basically, depending on the amount of structural damage the patient has at baseline, if the patient has very little structural damage at baseline, those patients will continue to not have structural damage even after 8 years. In other words, if there's no erosions, if there's no joint space narrowing the patient first presents, those patients will continue to have a good prognosis. Whereas the other group of patients, if they have structural damage at baseline, those patients will continue to progress over the next 8 years. So there seems to be at least 2 separate subtypes of rheumatoid arthritis related to the amount of structural damage. So in other words, if you've got no structural damage on MRI at baseline, even though the patient has got rheumatoid arthritis and has got inflammation, at 1 year and at 8 years, those patients will progress will continue not to have any structural damage. Whereas if you start off on your baseline MRI with a lot of structural damage, then you will continue to progress over the next 8 years. So based on the amount of structural damage on baseline MRI, MRI can accurately predict long-term structural damage. There are essentially 2 groups of patients: non-progressive structural damage, which is seen in about 2/3 of patients. They have very little structural damage at baseline, and they do not progress over the subsequent 8 years. Whereas the second group, they start off with structural damage, and they do continue to progress. Now, you might say, why hasn't this been shown before? Why has this just been shown in some recent papers or a recent paper? Well, effectively, the longest MRI follow-up before this was only 2 years. And you will not be able to see this sort of distinction. It's only if you follow up the patient over 8 years can you clearly see that clear pattern. And there's also been some studies looking at synovial composition. And these are separate independent studies that have been performed over the last couple of years. And they actually show there's also 2 types of synovium or synovitis in patients with rheumatoid arthritis. About one third of patients tend to have a plasma-rich synovitis, and about 2/3 of patients tend to have a plasma-poor synovitis. So the percentages marry up very, very nicely with levels of structural damage seen on MRI. But nobody's done a study looking at the MRI features and correlating that with the synovial composition. So that's a study that would be very useful to do. Okay, finally, what about median nerve swelling in carpal tunnel syndrome? It's very difficult clinically to make a diagnosis of carpal tunnel syndrome in rheumatoid arthritis because so many of the symptoms with hand stiffness, paresthesia, and pain that you see in people with rheumatoid arthritis are also seen with carpal tunnel syndrome. So you have to tend to rely more on auxiliary tests to make that diagnosis. And again, the same researchers, when they looked at the median nerve, they found that the median nerve swelling, which was greater than 15 millimeters, which is indicative of a tendency to carpal tunnel syndrome, was seen in 1/3 of patients, rheumatoid arthritis patients. So about 1/3 of rheumatoid arthritis patients have got median nerve swelling greater than 15 millimeters at baseline. And we normally think that the carpal tunnel in rheumatoid arthritis is due to synovitis and tenosynovitis. So when you improve that, it will go away. But this study showed that even though you improve the synovitis and improve the tenosynovitis, the carpal tunnel or the median nerve swelling does not improve. So in other words, median nerve swelling and actually median nerve swelling tended to be seen in more patients at 8 years and not related to synovitis, tenosynovitis, or structural damage, but it is related to functional disability. So it's more related to a generalized stiffness of the tissues that you get in people with rheumatoid arthritis that's most likely causing that median nerve swelling. So in that respect, I was quite interested in this other study that used this sequence called displacement encoded stimulated echoes, or dense MRI, and they basically looked at the wrist and radial and under deviation, and they were able to show that tissue stiffness was twice as high in rheumatoid arthritis patients compared to healthy controls. So again, it's another sort of technique that's available to us. So I think, okay, we may not be using MRI to help at the moment with the clinical evaluation of rheumatoid arthritis, but still MRI can potentially tell us a lot more about the pathophysiology of rheumatoid arthritis, and that's another sort of aspect. So in conclusion, MRI generally, I think, is underutilized in the assessment of rheumatoid arthritis. Automated programs have been developed to quantify both synovitis and bone marrow edema. Proton density fat saturated imaging can potentially replace T1 fat saturated imaging with contrast for the evaluation of synovitis and tenosynovitis in the rheumatoid wrist, but not in the knee, as we've heard. And MRI also tells us a lot more about the pathophysiology of rheumatoid arthritis. It tells us that, or it has shown us there tends to be two different types of rheumatoid arthritis with respect to the structural damage. About 1/3 of patients tend to have progressive structural damage. About 2/3 of patients have non-progressive structural damage. And these can be accurately or quite accurately distinguished based on baseline MRI assessment. And median nerve swelling is seen in about 1/3 of rheumatoid arthritis patients at baseline, and about half of these patients at 8 years. It does not regress with improvements in synovitis and tenosynovitis, and may be related to generalized stiffness of the tissues in people with rheumatoid arthritis. Thank you very much indeed. Thank you.
I'll just use one mic, otherwise there's too much echoes. We have a few minutes. Do you have any questions for Dr. Griffiths? I don't think Dr. Gurumezi is here. Yes.
No, with respect to the rheumatoid factor and with respect to the sort of level of inflammation in the wrist, is it? No, generally no. There's no correlation in that regard, no. There are very slight differences in people with rheumatoid arthritis, rheumatoid factor negative and rheumatoid factor positive RA, but really not that useful, honestly. And doesn't correlate with the two different subtypes of rheumatoid arthritis, no. No, there's no sort of correlation there, no. Yeah, thank you.
So you talked about that median of the
Yes.
monitored the stiffness of the tissue. Can that stiffness be measured using elastic techniques and predict the outcome or the?
Well, I think it's some. Can it be measured using ultrasound? Is it? Yes, I mean, it's only the last few years that these papers have come out. This recognition that median nerve swelling is only very common in rheumatoid arthritis has just been published last year. It is, and then the other paper about MRI looking at stiffness has also just been published in the last couple of months. So, I mean, you're quite right. Elastography and these things can potentially be used to evaluate that in the future. Yes, yes. Yeah, no, I agree totally. If basically, if you see a patient, oh yes, the question is if you see a patient with monoarthritis, and because especially in India, you know, tuberculous synovitis would be, or tuberculous arthritis would be a very common differential. Again, associated erosions, etc. Because how can you make that distinction? I think clinically, if the picture fits with respect to the possibility of tuberculosis, then you really have to do a synovial biopsy. And synovial biopsy is a very ultrasound-guided synovial biopsy is an incredibly useful technique that we do a lot of. And I think generally it tends to be underutilized, but it's a very accurate way of detecting both tuberculous synovitis or tuberculous infection, but also other types of infection, like post-operative infection. So it's very helpful, yes.
I have one question. All those big nerves, median nerves,
yes,
in rheumatoid arthritis, were they all symptomatic?
Well, that's a good point. I mean, because it's so difficult to make that distinction. Do you know what I mean? Because people with wrist rheumatoid arthritis will have so many of the symptoms of carpal tunnel syndrome. They're very difficult.
Yes.
Yes, thank you.
Thank you so much, Dr. Griffiths. So next, I would like to call Dr. Muthuswamy Chandramohan. He is a good friend of mine. We've been lecturing together for now 2 decades. He is a consultant musculoskeletal radiologist and a sports radiologist from Bradford Teaching Hospitals, NHS. And he's also an honorary senior lecturer in Leeds, and he does honorary sports radiologist for Bradford Bulls Rugby League Club. And he's also a visiting professor in Savita Medical College Hospital in India. He has got multiple achievements. It's huge ones. Sorry, I'll just read 3 of them because we have short of time. FRCR 2B examining board member of the Royal College of Radiologists. So if anybody wants any information about exams, is a member of sports subcommittee and of the European Society of Skeletal Radiologists, and also a member of arthritis subcommittee. So today, Chandramohan is going to talk about pitfalls in MR imaging of axial spondyloarthritis. Thank you.
Thank you, Girish, for the kind introduction. Right. Can I have my first slide? Not that one, sorry. Not that one. Can you go back? No, this is not mine. Can you go back? Number 9, if you go to number 9. Next one. Yeah. Thank you. Okay, so what we're going to do is in the next 20 minutes to look for the common pitfalls in the MR imaging of axial spondyloarthritis. Okay, so as we all know, clinical assessment and imaging findings are very important for the diagnosis of axial spondyloarthritis because we use treat to target approach to prevent long-term complications in this group of patients. And MRI is the ideal modality of choice to detect the early disease, active disease in axial spondyloarthritis. And the bone marrow edema, which we rely on to detect the active disease, unfortunately has got a poor specificity, resulting in overdiagnosis. And therefore, it's very important for us to be aware of the common pitfalls that we are going to see in our day-to-day practice. And the most important thing is always the imaging findings should be correlated with the clinical tests and the blood tests. So on MRI, the active disease appears as a bone marrow edema signal, as you see here. In the bilateral SI joints, there's a periarticular bone marrow edema signal in both SI joints. It's active disease sacroiliitis. Another example showing bone marrow edema signal. In the spine, you see osteitis at the vertebral corners, also in enthesitis. You can see changes in the costovertebral joints. And also, you may see inflammation of the ligaments at the site of supraspinous ligament attachment or interspinous ligament attachment, which also constitutes active disease. if you have synovitis in isolation or capsulitis in isolation, that doesn't form active disease, or you can't classify as axial spondyloarthritis as per the assessment of spondyloarthritis International Society criteria. Structural lesions, we have bony erosions, okay? Like here, you can see there is a bony erosion on either side of the sacroiliac joint, and you will have a backfill, okay? When it heals with fat deposition, and there will be fat metaplasia, that's called backfill. And also, subsequently, you can have a sclerosis, periodicular sclerosis, and eventually fusion of the sacroiliac joint. And the same thing you can see in the spine. You can have osteitis in the vertebral bodies, vertebral corners, and also you have changes in the discal vertebral joints that also be affected in axial spondyloarthropathy. So why it is important to get it right first time? Here is an example of a 53-year-old female patient who had MRI of the spine and SI joints in the evaluation of axial spondyloarthropathy. The MRI spine was normal, but whenever we see bone marrow edema signal on either side of the sacroiliac joints, we tend to call as sacroiliitis. So this patient was named as sacroiliitis, and this patient had treatment for axial spondyloarthritis with biologics. So this patient had a further imaging after 5 years, and again you can see bone marrow edema signal on both sides. It's very tempting to call this as axial spondyloarthritis, but this patient also had a CT abdomen in the meantime, and when you look at the CT pelvis images, and you can see there is a sclerosis on either side, there's a vacuum phenomena in the SI joints. So that's a classic appearance of degeneration, okay? It's not axial spondyloarthritis. So even inflammatory changes which happens in the spine can also occur in the SI joints and can be easily mistaken as axial spondyloarthritis. So in this case, this patient was misdiagnosed as axial spondyloarthritis and was given on biologics, and this can lead on to problems, and this went on to have a medical legal litigation. The next patient is a 28-year-old female patient, had a postpartum back pain for more than 3 months. She gives history of psoriasis and the inflammatory features and raised CRP. And again, you can see the SI joints. There are some changes on both sides, predominantly fatty metaplasia, and also there is some sclerosis on either side. And again, if you're not if you're not careful, you can easily call this as an axial spondyloarthritis. But if you use other sequences like a gradient sequence or a T1 wipe sequence, then you can appreciate whether there's any presence or absence of bone erosion. And in this patient, you don't see any bone erosion. What we see is a subchondral sclerosis on either side, which is typical of osteitis condensans ilii. Okay, in the spine, there are some subtle changes in the vertebral corners. Very difficult to tell whether this is active enthesitis or something else. So this patient was treated as a mechanical changes rather than inflammatory arthropathy. So patient came back 2 years later, and now we can see active osteitis, enthesitis in the vertebral bodies, and also there are changes in the costovertebral joints on either side. Okay, so in this patient, the diagnosis of axial spondyloarthritis was delayed by 2 years because we got carried away by the OCI in this SI joints. So why does it happen? SI joint is unique in terms of anatomy as well as the histology, and therefore undergoes pathological changes depends on the age of the patient and the sex of the patient. And like spine, you can also have degenerative changes, very common than axial spondyloarthropathy in the SI joints. And it's not uncommon to have two or different pathologies happening at the same time. That can also cause problems. And I want to draw your attention to the axial psoriatic arthritis, which behaves slightly different from the traditional axial spondyloarthropathy. So let's look at some examples here. The first patient is a 26-year-old female patient presented with the back pain, and you can see bilateral SI joint changes. There's periodic bone marrow edema on either side. So would you call this as axial spondyloarthritis? What could it be? Could be mechanical. The location is typical, okay, and this is nothing but an accessory sacroiliac joint. Again, it's very common to have mechanical changes in sacroiliac joints, including the accessory sacroiliac joint, that can be easily mistaken as sacroiliitis. Like Modic and plate change, the accessory SI joints also undergo degeneration. It goes through a process of osteitis, fat metaplasia, sclerosis, and ankylosis. That can also be can also cause confusion and can be mistaken as axial spondyloarthritis. As I told you, it can be unilateral. That again can cause further confusion. And when it fuses, it can appear as a ankylosing associated with axial spondyloarthropathy, especially on plain film. You can easily mistake as a bony ankylosing. What about this patient, 31-year-old, history of childhood JIA, was on remission for 20 years and now recurred with low back pain. And you can see changes on the right side of the SA joint. Again, if you're not careful, we can call this as a sacroiliitis, but on the T1 weighted sequence, you can show the lumbosacral transitional vertebra that can also undergo mechanical changes and can be symptomatic, as in this patient, which we call as a Bertolotti syndrome. Preauricular sulcus exclusively seen in females because of the ventral attachment of the sacroiliac ligament. It can appear very deep, and on the plain film especially, you can mistake that as a bony erosion associated with sacroiliitis. Right, what about this patient? 19-year-old female who was investigated for axial spondyloarthropathy. And if you look at the sagittal T1 weighted sequence, there are areas of fatty change at the corners of the vertebral bodies. Could this represent fat metaplasia associated with axial spondyloarthritis? It's not, because it's a very uniform, and this is nothing but a ring apophysis which can simulate a fat metaplasia associated with axial spondyloarthritis. Again, it's very common, and in CT it can look like a typical Romanes lesion. Okay, so you can see multiple level of sclerosis at vertebral corners, and you should not mistake this as a Romanes lesion associated with axial spondyloarthritis. So how can you differentiate? Ring apophysis is very uniform and symmetrical when compared to the Romanes lesion you see with axial spondyloarthropathy. So an example of inflammatory enthesitis or apophysitis in a patient with a JIA, and you can see a discrete bone marrow edema signal, which shouldn't be a problem in making a diagnosis of inflammatory arthropathy. Okay, what about this patient? 42-year-old female with inflammatory back pain. As you all know, the inflammatory changes not necessarily affect the vertebral corners, it can also affect the discovertebral joints. And here you can see the irregularity of the discovertebral joints. Okay, so you should not mistake this as a axial spondyloarthritis, because we have in addition this wedging of the vertebral bodies, Scheuermann's disease. Okay, here is an example of Anderson lesion associated with inflammatory spondylodiscitis, where you can see the erosion of the vertebral end plates. There is severe bone marrow edema around that vertebral end plate, and so that is a classic Anderson's lesion associated with inflammatory spondylodiscitis. And when it heals, you can see the change of fat metaplasia around the vertebral end plates. What about this patient, a 23-year-old female with suspected axial spondyloarthritis, and you can see some changes in the SI joint. It can mimic like a backfill, but it's not. It's the normal endochondral ossification as a process of maturation of the sacroiliac joint, and that can be easily mistaken as a backfill associated with axial spondyloarthropathy. So how does a backfill look like? And that's how it looks like. You know, whenever you have a backfill, there will be a fat metaplasia, and the signal characteristic is different from the normal marrow signal if you compare with the rest of the bone marrow. So degenerative changes, modic end plate changes, type 1 and type 2 can also mimic like axial spondyloarthritis. So it's very common, and if it happens in the lumbar spine, it's easy, but sometimes it can happen in the thoracic spine, and where you can get confused with the Anderson's lesion. So how can you differentiate? Again, you can see the definite erosion of the end plates when compared to the modic change. There's a lot of bone marrow edema, and of course you look at elsewhere to look for other features of axial spondyloarthritis. What about this patient? Could this represent Anderson lesion? Yes, it could. But if you look here, there are, on the T1 weighted sequence, there are some signal changes going into the vertebral bodies, and there is a subligamentous spread, and this patient had a TB spine. Okay, so that also can mimic like a axial spondyloarthritis. Osteitis congenita ileus is very common. Okay, so it's very easy to diagnose on the plain film and on the CT. So if you have any confusion of whether to call it as OCI or whether to call it as axial spondyloarthritis, do some specific bone erosion sensitive sequences in MRI. You can do a gradient sequence, or you can do a T1 wipe sequence to look for the periodical bone erosion. But it's simple. If you have a previous imaging to correlate with, the patient had a previous CT abdomen and pelvis, look for the SI joints, and that's a classic appearance. Okay, you got a vacuum phenomena, sclerosis on either side. That's typical of osteitis congenita ileus, very common. However, this is an example of bone erosion associated with axial spondyloarthritis, where you can see a bunched out erosions on either side, and there's subchondral sclerosis. That's different from OCI. OCI can be asymmetric if it's bilateral, or can also be unilateral, adds further confusion. Again, if for access for a previous CT, have a look at it, or you can do CT like MRI and other techniques that are available in MRI to differentiate between axial spondyloarthritis and OCI. So whenever you see a unilateral joint disease, what do you suspect? Unilateral SI joint disease. Yeah, infection. Okay, so you have to consider infection first, but not all the time. Okay, here is a 23-year-old professional athlete, felt pain while playing football, struggling to weight bear, and MRI shows changes on either side of the SI joint. On the right side, the left SI joint is normal. This could be infection, yes, but there are no other features to suggest infection both clinically and radiologically. And this was later proved to be due to axial spondyloarthritis, unilateral sacroiliitis. So you can get unilateral changes with axial spondyloarthropathy. Whereas in contrast to septic arthritis of the SI joint, history will be typical. Patient will be in acute pain, severe pain, and also on MRI, you will see this soft tissue edema around the SI joint, which you don't see with axial spondyloarthritis. Okay, so the key finding to look for is you may see a joint effusion, but the key finding is the presence of extensive soft tissue edema around the SI joint. What about fat metaplasia? You can see fatty corners in this patient, multiple level. Yes, this could be a fat metaplasia associated with axial spondyloarthritis, but degeneration is much more common. So don't get fooled by the presence of fat metaplasia with the degeneration. Okay, you can't differentiate. Okay, so if this is an example of fat metaplasia due to degeneration, and this is a patient with known axial spondyloarthritis, it's very difficult to differentiate. So you look for other findings. Okay, so not necessarily this the MRI scans, but the key thing is to look at the patient's clinical presentation and look at the bloods. What are the conditions that can resemble axial spondyloarthritis? Okay, here is one patient, 95-year-old male with a back pain, and you can see the rigid spine due to fusion of the vertebral bodies in the thoracic spine. There are some changes lower down, and this patient's pain was mainly due to the fracture of the thoracic spine. Okay, here the SI joints are normal. Age of the patient is very useful. Patient is 95 and no SI joint fusion. What is this condition? DISH. Okay, diffuse idiopathic skeletal hyperostosis is very common. Okay, that can resemble like axial spondyloarthritis. This is an example of axial spondyloarthritis. You can see the change is different from what we saw earlier. So there is a fusion of the spine and disc vertebral changes with fat metaplasia. So this are all structural lesions associated with axial spondyloarthritis, and you can see the fusion of the SI joints bilaterally. So this is due to axial spondyloarthritis. Life is not straightforward. Okay, we have in radiology there are more than 56 shades of gray. So in DISH also you can have fusion. Okay, so it's very, if you are really interested, you can read this paper talking about the changes that happens in the SI joints with the DISH. So just be careful, not all the time we are going to have a normal SI joints. With the DISH, there are so many changes can happen, which includes the presence of an anterior pararticular osteophyte, again on the plain film that can look like an enclosed SI joint. And also you can get enthesitis related changes in the osteophyte. You can see the capsular thickening, which enhanced with contrast. So this was initially mistaken as an enthesitis associated with seronegative arthropathy, but this was just because of DISH. Okay. I just want to draw your attention to axial spondyloarthritis associated with psoriatic. Up to 35% of patients will have radiographic spondylitis without sacroiliitis. So that again causes confusion with DISH. And if it happens, sacroiliitis, it can be asymmetrical or it can be even unilateral. And it tends to affect the cervical spine and posterior elements. So not always look for the osteitis in the vertebral corners. And the syndesmophytes in axial psoriatic arthritis resemble like a DISH osteophyte. It's very chunky. It can be asymmetrical, can mimic like even degeneration. So here is an example of a 57-year-old male with a neck pain and radicular pain in the arm. He's got cervical radiculopathy, and you can see the bridging osteophytes in the cervical spine. 9 out of 10 times this is going to be a DISH Forster's disease, right? But when a patient with axial psoriatic arthritis, you have to be a bit careful. So this patient had an MRI scan, and you can see the fat metaplasia at the corners of the vertebral bodies in the cervical spine and upper thoracic spine. And this is not DISH, this is a syndesmophyte associated with psoriatic arthritis. Another example, a 26-year-old female with a new diagnosis of psoriatic arthritis, and she had a C-spine pain, and here you can see isolated change affecting the anterior-inferior corner of the C2 vertebral body. So whenever you do MRI, you have to do the whole spine, particularly in a patient with, when you're suspecting psoriatic arthritis spine involvement. Okay, so your MRI protocol should include the whole of spine. Another example of axial psoriatic arthritis, again, when you do the C-spine, you can extend to include the mandibulosternal joint. You can see the osteitis involving the mandibulosternal joint. You can see the ligamentitis involving the interspinous and supraspinous ligaments. Okay, and all structural changes in the SI joint. So axial psoriatic arthritis has got a slightly different pattern than your usual inflammatory spondyloarthropathy. Ligamentitis can occur in other areas as well. Here you can see there is a edema involving the epimysium thoracolumbalis muscle fascia, and also you can see edema in the interspinous ligament. This is very common in your MR imaging. Okay, so edema in the interspinous ligaments is very common, but you give importance only if you are suspecting patients with axial psoriatic arthritis. Another example of degeneration-related changes in the interspinous ligament, and this patient has got a back pain, and you see there's a pseudoarthrosis between the spinous process of L4 and L5. This is a Bastop's disease. Okay, so in isolation, don't give importance because it's very common finding in the MRI lumbar spine. But if you're suspecting patients with axial psoriatic arthritis, especially when they don't have any changes in the SI joint or the facet joints, then you give importance to that finding. So finally, take-home messages. Beware of normal variations that can stimulate axial spondyloarthritis. Just be familiar with the pattern and distribution of axial psoriatic arthritis. And finally, imaging findings are irrelevant if they don't fit with the patient's symptoms. Okay? My last case, a 50-year-old male who's got MRI spine. How many of you can make a diagnosis of axial spondyloarthritis in this patient? Difficult, right? If I give you a plain X-ray, how many of you can make a diagnosis of axial spondyloarthritis? Okay, so rigid spine, it can appear normal on MRI. Okay, so always correlate with plain X-ray, otherwise we'll make fool of ourselves. So look at plain X-rays, or even if the patient has CT abdominal pelvis, look at the spine and SI joints before reading MRI spine for axial spondyloarthritis. Thank you.
Thank you, Dr. Chandramohan. Now I call upon Dr. Manikyam Subramaniam to come up on stage, and Dr. Manikyam Subramaniam will be talking on crystal arthropathies on imaging, detection, patterns, and extra-articular manifestations. He is a consultant in Phuket Pot Hospital, Singapore. He's an adjunct clinical tutor in Lee Kong Chieng School of Medicine, Nyang Technology University, Singapore. His interests are trauma, sports medicine, and interventions for pain relief, and he has published more than 20 peer-reviewed articles in various journals, presented posters, and gave invited lectures at various national and international conferences. Thank you, Dr. Subramaniam.
Thank you, Dr. Girish, for the kind introduction. So, I have no actual or potential conflict of interest in relation to this program or presentation. So, what we are going to see in next 20 minutes, introduction to crystal deposition arthropathies, the pathophysiology and common causes, the imaging features, role of DECT, and conclusion. So, introduction. Crystal deposition arthropathies are group of diseases due to deposition of crystals in and around the joints which cause inflammation. So, gout is the most common crystal deposition arthritis, which is due to deposition of the monosodium urate crystals. So, the crystals are needle shape and then it has negatively birefringent. So, second, this is what we are going to see is calcium pyrophosphate dihydrate deposition disease. The acute presentation is commonly referred as pseudo gout. It can be asymptomatic or it can be chronic pyrophosphate arthropathy as well. So the crystals, the calcium pyrophosphate crystals are rhomboid shape and then it is positively birefringent. The third disease is hydroxyapatite crystal deposition disease, in which there is deposition of the basic calcium phosphate, which are very small, and then there is no birefringence. This hydroxyapatite crystal deposition disease is commonly deposited in the tendons and bursae around the joint. So let's see gout. So what are the pathophysiology and common causes? So overproduction or under excretion of the uric acid, which results in the elevated uric acid level, results in urate crystal formation, which interact with the inflammatory system, results in acute gouty arthritis. So gout can be primary, so it results due to abnormalities in purine metabolism, can be idiopathic or reduced excretion of urate, may be familial. Gout can be secondary due to excess uric acid production due to neoplasm or lymphoproliferative disorder, renal failure, alcoholism and cytotoxic drugs. So what are the clinical stages of gout? First stage is asymptomatic hyperuricemia, in which there will be no symptoms and then only the blood test will show hyperuricemia. The second stage is acute gouty arthritis. Is painful, initially monoarticular, commonly involved is first metatarsophalangeal joint, which is podagra. You can see the schematic thing. This James British caricature, he is demonstrating the pain as a demon eating the bones. Then the third stage is the intercritical gout. It's between the acute attacks. And then the final stage is the chronic tophaceous gout, in which there is tophi deposition, which usually starts 10 to 12 years later, which is a chalky, cheesy, yellow-white deposits of crystals in the periarticular soft tissue, ligaments and tendons. So commonly involved joint, first MTP joint is most commonly involved. The appendicular skeleton is most involved, then the axial skeleton. The involvement of the lower extremity is more common than the upper extremity. Although any joint can be involved, usually the small joints are involved, in which the CPPD, the second disease we are going to see, is most commonly involves the large joints, particularly the knee joint. So gout can be oligoarticular, can be polyarticular as well. It can be bilateral, but generally shows asymmetric involvement. What is the role of imaging? As far as arthritis is concerned, diagnosis is usually made on clinical and laboratory findings. This was already emphasized many times by Dr. Ali Gurmesi and Dr. James. So imaging plays a role to confirm the diagnosis, or when there is atypical presentation such as gouty tophus mimicking a mass, or when the tophus is involving the deep location. Imaging also plays a role in differentiating gout from other crystal deposition arthropathies and sometimes infection when it is acute presentation. Imaging also helps in the quantification, monitoring the treatment response and in follow-up of patients with gout. So these are the radiographs of the chronic tophaceous gout, shows all the classical findings of the chronic tophaceous gout. You can see punched out juxta-articular erosions with overhanging edges. You can see multiple erosions everywhere. You can see that bone density is preserved until late in the disease. The joint space is preserved. Another one more imaging finding is this soft tissue tophus, which can be slightly hyperdense to the soft tissue, which is deposited in the periarticular soft tissue region. First, most commonly affected is the metatarsophalangeal joint. This tophi can be calcified in patients with renal failure. So another patient showing a large soft tissue tophus mimicking a mass sitting in the patellar tendon, causing erosion of the tibia. You can see the tophus. Another patient elbow shows a pathological fracture and a large erosion. You can see there is soft tissue tophi in the olecranon and bursa as well as in the soft tissues adjacent to the joint. So these are the findings of the chronic tophaceous gout. Ultrasound is useful to detect early gout. You can also see nerve compression, monitoring the treatment response as well as needle guidance for aspiration of the joint fluid. There are signs described in the literature, a double contour sign, that is the urate deposition over the cartilage, that is over the hyaline cartilage, seen as an irregular echogenic line. Tophi can be soft or it can be hard. It can obscure underlying structures. There's another sign that is described in the literature, a snowstorm appearance, which is hyperechoic foci in the joint fluid, which represents microtophi. So these images are from the Dr. Girish article. Ultrasound clearly demonstrates intratendinous tophi deposition. So this patient, you can able to see the tophus deposited within the tarsal tunnel, causing the compression. So let's coming to the role of DECT. Why DECT in gout? Because hyperuricemia may not be seen in up to 40% of the patients, and not all patients with hyperuricemia will have gout. One. The second thing, joint aspiration, crystals may be absent in up to 25%. When the joint fluid is less, it may not be sufficient to aspirate. Okay. Then the plain radiographs, ultrasound, conventional CT and MR are not sensitive to detect early gout. The DCT is highly sensitive and specific, and most validated use of DCT is in the gout. So this you can see there is a large soft tissue mass-like thing sitting in the patellar tendon, causing erosion of the tibia. You can see this T2 weighted image. One characteristic finding in MRI is you can see there are erosions, but there is absence of edema around the erosion. So this case turned out to be a gouty tophus, which is sitting in the patellar tendon. DECT confirms it is the nature of the thing, avoids biopsy. This young patient presented to us with a numbness and weakness of bilateral lower limbs. So this is a T1 weighted image and T2 weighted image, fat sap. You can able to see the anterior epidural space. There is T1 iso-intense, T2 hypo-intense long lesion, which showed enhancement with contrast. Not a known stage, not a known gouty patient. So we really don't know what it is. We thought it could be a lymphoma, some things. Then we did the CT shows the hyperdense material in the anterior epidural space. These are the soft tissue window. You can see it is hyperdense in the anterior epidural space, and DCT clearly shows the tophus deposition within the epidural space. This one we published in skeletal radiology. So you have to be mindful of artifacts. This is toe nail bed artifact. This is skin callus, and then sometimes image noise can also which may result in the over quantification of the urate deposition. So coming to the next, calcium pyrophosphate deposition disease. Arthritis with evidence of calcium pyrophosphate dihydrate deposition within the articular cartilage. So gout, the tophi, the monosodium urate crystals are deposited over the hyaline cartilage. In CPPD, these crystals are deposited within the articular cartilage. So CPPD can be of three forms. One is chondrocalcinosis, which is most common, can be seen in most of the elderly patients, which is asymptomatic. Another one, CPPD can be present as acute arthritis, commonly referred to as pseudo-gout. Chronic pyrophosphate arthropathy is a chronic form of CPPD. So mostly seen in elderly patients with no gender predilection, while gout is commonly seen in middle-aged men. Knee is the most commonly affected joint. Crystals are rhomboid shaped and positively birefringent. The imaging findings of CPPD, features of osteoarthritis with unusual features such as, one, it can be symmetric in distribution. Normally, osteoarthritis commonly involves the weight bearing. For example, in the knee joint, you commonly see the changes in the medial tibiofemoral compartment. But if you see osteoarthritis which is symmetric in distribution involving the knee or involvement of the non-weight bearing areas, particularly patellofemoral joint with erosions, you should suspect chronic pyrophosphate arthropathy. So this CPPD can typically involve few joints. One is the knee joint, followed by the hands, in which there is involvement of the intercarpal and metacarpophalangeal joints with hook-like osteophytes. Subchondral cysts are common. So common locations for chondrocalcinosis, knee is the most common, followed by pubic symphysis and wrist. Arthropathy, knee joint is the most commonly affected, followed by wrist and hand. Spine, which is around the dens process, crown dens. So you can see in this patient, you can see there is chondrocalcinosis, 2 patients showing calcification within the menisci. Another patient shows calcification of the ligaments. Here you can see there is involvement of the metacarpophalangeal joints. This patient presented with acute pain, suspected gout, DECT was performed. So there is no urate deposition, but there is calcium deposition within the cartilage as well as within the menisci. So this is acute CPPD pseudo-gout. We are coming to the last topic, that is hydroxyapatite deposition disease, in which this deposition of the basic calcium phosphate deposited in the tendons and bursae around the joint. Shoulder is the most commonly affected joint, followed by external rotators of the hip. In the shoulder, the common tendon which is commonly get affected is the supraspinatus. In the hip, it's gluteus tendon, minimus and medius. Usually monoarticular, present as calcific tendonitis and bursitis. Patient presents with acute, severe pain and restricted motion. There are 3 phases: formative stage, resting stage and resorptive phase. Management is usually conservative. We can use NSAIDs, or sometimes we can use ultrasound guided dry needling or barbotage. So this is a case showing calcification in the region of the supraspinatus tendon. So it is a calcific supraspinatus tendinitis, but not all patients will be symptomatic. So this patient was presented with acute pain in the shoulder. So we did MR that shows there is thickening of the supraspinatus tendon, calcification within the supraspinatus tendon. You can see there is edema and fluid in the subacromial subdeltoid bursa. So it is acute calcific tendinitis due to hydroxyapatite deposition disease. You can see this calcification here is amorphous, fluffy, globular calcification in the region of the supraspinatus tendon. Ultrasound is very useful. It can detect even very tiny calcifications such as 2 mm also can be detected in ultrasound. This calcification, when they are very small or linear, may not show acoustic shadowing. These small calcifications many of the times will not be detected on plain films. So ultrasound is really very useful to pick up tiny calcifications within the tendon, and then it is also useful for dry needling and barbotage. Another patient presented with acute painful right shoulder. You can see there is calcium deposition in the region of the supraspinatus tendon. With X-rays, it is really difficult whether the calcification is in the bursa or in the tendon. The MRI image which was performed 2 days later, you can see the supraspinatus tendon is nice, but there is edema fluid within the subacromial subdeltoid bursa with calcification within the bursa. So these calcifications can known to move from the tendon to the bursa, as well as even it can move intraosseously. This patient presented with acute pain in the neck with difficulty in swallowing to the A&E. So referred to the ENT guys. They suspected retropharyngeal abscess. So first investigation, what we will do is plain radiograph of the neck. You can see here there is soft tissue calcification in the region adjacent inferior to the dens, anterior to the dens and below the anterior arch of the atlas. And there is no prevertebral soft tissue widening, no radio-opaque foreign body. So this is acute calcific longus colli tendinitis, very commonly mistaken, and then patient will be referred to ENT for suspected abscess. So the same patient underwent CT, you can see this is soft tissue window, you can see the globular, fluffy, amorphous calcification in the longus colli tendon, which shows edema. The sagittal images shows calcification in the longus colli tendon with there is prevertebral fluid. Sorry, you can see this prevertebral fluid, there is absence of rim enhancement. So normally in the case of retropharyngeal abscess, it is due to infection, so it will show rim enhancement. Here the fluid is reactive, so you won't see rim enhancement in hydroxyapatite deposition disease, but there will be fluid because it is reactive. So this is a case of acute calcific longus colli tendinitis. So when the patient presents with acute pain in the neck and suspected retropharyngeal abscess, you have to look for the longus colli calcific tendinitis. It's straightforward in the CT, but sometimes it may be tricky in MRI. So final slide. So the differentiations between the gout, CPPD and hydroxyapatite deposition disease. The age group, gout, middle age, men. CPPD usually commonly seen in elderly, no gender predilection. Hydroxyapatite deposition disease, middle age with slight women predilection. Most commonly involved joint, small joint. First MTP is most commonly affected. For CPPD, knee is the most commonly affected, followed by wrist. For hydroxyapatite deposition disease, shoulder is the most commonly affected joint. The crystals, monosodium urate, which is needle-shaped, negatively birefringent. For CPPD, it is calcium pyrophosphate, which is rhomboid-shaped and positively birefringent. BCP crystals are small, no birefringence. The crystal deposits in gout are over the cartilage. In the CPPD, it is within the cartilage. In hydroxyapatite deposition disease, it is deposited in the tendons and bursae. The classical imaging findings in the gout is periarticular erosions which are punched out with overhanging edges and soft tissue tophi. For CPPD, chondrocalcinosis, the osteoarthritis which is symmetric in distribution and the involvement of the non-weight bearing, for example in knee joint, involvement of the patellofemoral joint. For hydroxyapatite deposition disease, it's in the tendon and bursa, amorphous, fluffy, cloudy, globular calcification seen around the joint. So conclusion, the radiologist should be aware of various clinical manifestations of common crystal deposition arthropathies. The knowledge of various atypical presentations and imaging findings is vital in order to make an accurate diagnosis. DCT is very useful for accurate quantification of the urate deposition, monitoring treatment response and in follow-up of patients, and also useful in differentiation gout from CPPD. Gout is a common disorder, can present anywhere in the musculoskeletal system. So when in doubt, you should think of gout. Thank you.
Speaker is Dr. Vinesh Gandikota. He is a MBBS FRCR. He is a consultant in University of North Carolina, USA. His areas of interest are sports medicine, dermatology, and anesthesiology. He has got many achievements like National Research Innovator Award, multiple Excellence in Teaching Awards, multiple publications. He is a co-investigator in NIH, and he's a deputy editor of AIUM Journal. Over to you, Dr. Girish.
Thank you so much. Thank you for that introduction. So, second last, there's one more to go, so we'll be done soon. My topic is monoarthritis imaging algorithm, stepwise approach for diagnosis. Just one sentence. If it is monoarthritis, you just have to make sure it is not infection. And that's the lecture. That's done. So if you can take home that message, that is good. You already know that message. I just want to re-emphasize that. But since they gave me this topic and I realized it on the flight that, oops, I'm talking on this, I made a lecture a little longer so that it can last for 15 minutes. Monoarthritis is defined as pain, swelling, or restricted movement attributable predominantly to a single joint. In the foot, they relax it a little bit, like midfoot and so on, but generally a single joint. The diagnostic spectrum, meaning differential diagnosis, includes, most importantly, septic arthritis. So you want to make sure it is not septic arthritis. The second one, which we were just discussing, is crystal deposition disease, like gout involving a single joint, because anytime when it presents first, that is what it is, usually the first MTP joint, but it can present elsewhere as well. Calcific tendinosis, that can be very painful and look like gout or look like infection or inflammation. There is a lot of vascularity in some of these places. So these things can mimic monoarthritis. The third one is an atypical presentation of inflammatory arthritis, less common. It is generally a systemic process and symmetric and bilateral process, but that can also happen. And then there is a whole host of other stuff which can also get into this. Like, for example, trauma-based osteoarthritis. You have had a trauma in the past, it slowly builds on to become a horrible osteoarthritis of one particular joint, which is where the trauma was, or unilateral hip osteoarthritis, which is accelerated, so you have a lot of pain on one side of the hip alone. And then lastly but not the least is osteonecrosis. When you have osteonecrosis, there's a lot of pain, and then it collapses and you get osteoarthritis related to that. So these are the examples of monoarthritis. But as always, I said the first sentence, rule out septic arthritis. So what should the imaging pathway include? The imaging pathway should answer 4 sequential questions. First, is this truly intra-articular? There is pain anterior to the elbow. Could it be biceps? Could it be something else? Common extensor tendinosis. You need to figure that one out if it's not being clinically figured out. Then, is this an emergency? Is this infection, fracture, or neurovascular compromise? Following the third question is, does this need arthrocentesis? This is all the imaging pathway. And what additional imaging will most efficiently identify structural, inflammatory, or crystal-related or neoplastic disease? Is there an abscess? Should we give contrast? Should we do MRI? Should we do CT? So those are the 4th point. So this is your pathway. So how do we choose the modality on these things, right? So first of all, assuming that it is the joint, and we figured out that it is joint, the first question always is there an effusion? And for that, ultrasound is great. But X-ray is equally good for knee, elbow, and ankle, multiple choice questions. So where is the ultrasound, joint effusion good for X-ray? These are the 3 joints that it can pick up, even the smaller ones, if you get proper views. Is the aspiration needed is the second question. And if that is the case, you will do mostly ultrasound guided aspiration, but in some places you may not have that access. So you can also do fluoroscopic aspirations, like in hip, which is deeper joints. Sometimes we use it for shoulder as well. And CT for even deeper joints like sacroiliac joints, or where there is distorted surgical anatomy and you're worried about infection, there is a lot of stuff that you can't see through on ultrasound, you might use CT. Then, is there infection extending to bone or soft tissue? Natural question. Clinician is asking, how long should I do antibiotics? Is this bad? Should it be washed out? What is it? That is where MRI comes, often with contrast. Not necessary, but often with contrast. The contrast is most helpful when you're worried about necrosis or abscess. So this is how you want to carry on with infection. Now I said crystal deposition disease is also part of monoarthritis. So what should we do there? If gout is suspected, aspiration should be performed, okay? Because DECT will not be positive if you have fluid full of gout. DECT needs crystals to coalesce together to have about 2 to 3 millimeters of diameter. So they should be floating in a mass for you to filter back and do that kind of measurements that you get for Hounsfield units. So you will not get it. So joint effusion, just aspirate. DECT will be negative. If you cannot aspirate, then obviously you do ultrasound and see all those 3 signs and then go on for dual energy CT and so on. But aspiration should be done. If CPPD is suspected or crystal thing is suspected, or CHAD or calcium hydroxyapatite is suspected, then do radiography and ultrasound and CT for axial disease. If there is mineralized synovial lesion, then radiography and CT. And don't forget PVNS. PVNS is also the other thing which can present like synovial proliferation in edema and so on. So that also is in the differential for monoarthritis, even though it is not arthritis. Then trauma-based. Is there fracture or chronic structural disease? Then do x-rays. Is an articular fracture incompletely characterized? Then go ahead and do the CT, because, you know, I want to know, is the articular surface involved? That changes management a little bit. If articular surface is involved, is there a 2 millimeter gap in between? Then surgeon can do something to fix that gap, and so on. If there is an occult fracture and or something else in the bone marrow, then we need to do MRI with contrast. Ooh, I already ate my 7 minutes. So this is the imaging algorithm for monoarthritis, right? So if there is infection, if there is monoarthritis, infection has to be excluded. So first you do radiographs or ultrasound and look for effusion. If there is effusion, aspirate, send it for culture and crystals. If there is suspicion enough for that, go for that. And if the extent or failure has to be defined. Okay, so the next thing is, what are the key messages? Aspirate before antibiotics are clinically safe. Crystals do not exclude infection, so always do both. Even if there is gout suspected, send it for culture because they can have both. A lot of people, clinicians, just put the needle in, put steroids in and so on, so they may have super infected the pre-existing gout, so you need to do that. And do not wait for MRI if aspiratable effusion is present. So this is the core rule for those who are not working remote, for those who are not in scan centers, or for those who can do these things. Do this first. Do not let MRI delay aspiration when septic arthritis is possible. MRI is needed when there is negative aspirate but high suspicion, when the hip, sacroiliac joint, sternoclavicular joint, or other deep complex joints are involved, if there is suspected osteomyelitis, abscess, pyomyositis, tenosynovitis. So next stage, MRI gets involved. And obviously for contrast, I said, collection or necrosis. That's where you go for contrast, or if you're worried about synovial mass. So this is another place. I can even stop here for this particular lecture. But I kept on making this one, so it became longer. Now, so this is the ultrasound. We use ultrasound guidance because it can do all these things which you can read, right? It can find the loculated fluid that is amenable for aspiration, because there may be a lot of loculations. One may be very complex, another may be slightly simpler, so you can aim for those things. Fluoroscopy does not help you do that. It just blindly gets into one place. So wherever possible, try and do the ultrasound aspiration. If you cannot, or if you have to, then the fluoroscopy is generally used for hip or some shoulder and wrist. CT guidance for sacroiliac joints. I still like sternoclavicular joints with ultrasound, but if you're worried about it, if you want to see if there's any opening in the back side of the sternoclavicular joint so that you can stop the needle, or you don't want to do the procedure, do get a CT first, and then complex postoperative anatomy. Dry tap, one thing I want to say is saline lavage. Some of these institutions do that. When there is a dry tap, you put in saline so that you get something back, and you can send that for culture and everything else. But that is something that is locally defined. Like, does the local microbiology and surgical protocols involve that saline lavage? What do you send it for? These are the things, you know, and this is roughly what the infection is usually associated with. Maximum, most of the times it's staph, but it can be strep, gram-negative, and other stuff. So send for all this stuff that is mentioned here, including aerobic and anaerobic. So you should have a lot of fluid, if not, at least get the culture done. So the first sign, first imaging that I'm showing to you is already in 10th minute, is that the joint space is concentrically narrowed in infection, okay? The hip joint space is concentrically narrowed in infection. What does that mean? It means diffusely it is narrowed down compared to osteoarthritis, where it is eccentrically narrowed. Some portions are narrowed, some portions are not. This is osteoarthritis. This can be inflammatory arthritis, or in certain conditions, infective arthritis. But this is osteoarthritis. So always look for that. More importantly, look for osteopenia for early signs of radiographs in terms of early infection. This is crystal deposition disease and can be asymptomatic and quite common in elderly people. Moving on to infection in MRI. So the thing that I think Dr. Chandramohan was mentioning is that it has a huge collateral damage. If there is infection in the ankle joint, there's edema on both tibia and the talus, and extensive surrounding soft tissue edema, so much that you then start thinking about infection. In this particular case, there is no much synovium, there is a lot of fluid. You probably will be able to aspirate that. So this is early onset septic arthritis. This is a little subacute septic arthritis. There is still fluid there. I have not had the post-contrast images will demonstrate synovial enhancement. So there is more synovium forming. The distal tibiofibular joint is gone. The syndesmosis is gone. The sinus tract is evolving. So this is kind of subacute version of it. But you will notice that even in the subacute version, there is still a lot of edema persistent. Now, this one is a chronic type of synovitis. There is more synovium everywhere. There are erosive changes. There is edema, everything else. And this is when you start walking into the territory of not common associated synovitis, like, for example, you want to think TB, chronic arthritis, fungal disease, and so on. So as you go further away, as the synovium amount increases, as the complexities increases, as the time increases, the diagnosis also can include some atypical bugs in it. So that is the version of arthritis. This is a case of 55-year-old with knee pain. I'll have to go faster. This is not joint-based, okay? But if you look very carefully, there is something within the tibia here, lucency with surrounding sclerosis. You do an MRI, you then realize that this is actually tibial osteomyelitis, secondary septic arthritis. If you do the CT, you will see the sequestrum, the involucrum, the tract going through this, and so on. So there is some role of CT in the infection. This is where it is. It's coming down to defining the osseous involvement much better. So this is osteomyelitis leading to septic arthritis because it is so close and getting into the joint. Here is one place where if it is unilateral, you really should be thinking about infection. The other thing about infection is it has a very ill-defined articular surfaces, no matter where it is, whatever joint you deal with it. If it's very ill-defined, even the erosions are ill-defined, and there's a lot of osteopenia, think infection. This is the sacroiliitis unilaterally, nothing else but infection. And if you look at it, there is this edema, and there is edema even in this muscle and so on. So it is diffusely involving everywhere, all around it, unilateral sacroiliitis. In terms of crystals, which I have 6 minutes, that was the infection part, and that is the critical part, right? So we talked about if it is unilateral sacroiliitis, I think you should just think about infection, and everything else we spoke to you about how to approach that. Crystals is the same thing. The first attack, the atypical presentation, possible sepsis, this is always a problem. Even if you think it's gout, a lot of people will say that the exudate of gout looks like infection. It looks like pus. So that is a problem. So then if you suspect gout or CPPD or anything else, try radiographs first. You should. And then if you see something, great. If not, go for ultrasound, and ultimately you need aspiration. So in ultrasound, we talked about all this. I don't want to go through this. We just had a lecture, but there are issues. But majority of these are not acute findings. They are subacute or chronic. In fact, DECT has got almost no role in acute gout. In fact, DECT has no role in a rheumatologist's office, generally speaking, unless they want to manage in some way how much crystals there is, and they want to assess quantifying, because they generally know that this patient has gout in DECT is usually for diagnosing tophus. Where DECT is helpful is when the patients come from other people, not rheumatologists, from surgeons and elsewhere, and you want to prove to them that this is not a mass, this is gout. So here is a joint effusion. This happened to be gout, but it can be infection or anything else. It doesn't stand out. You just see the fluid, you put a needle in, you aspirate. That's how you manage monoarticular joint effusions and exclude infection. Sometimes it is within the tendon itself, like for example this one. There is this crystals within the patellar tendon, and if that is the case, put a needle in, aspirate, and send for gout crystals. Okay, This patient presented at sports medicine clinic with a suspected quadriceps tendon tear, actually re-tear. So this came to us from the sports medicine guy. He said, hey, I operated on this quadriceps tendon and it looks like it has re-torn. So that was the indication on ultrasound. We saw that on ultrasound. It did not look like re-tear. Gout loves surgical or post-surgical locations. So it will go and settle there very well. This was gout. But how do we prove to a surgeon that, look, we're not dealing with a tear, we're dealing with material density deposition. This patient did not have gout elsewhere. That is the perfect time to do dual energy CT to demonstrate the amount of gout crystals that have finally settled in. The other clinicians, the rheumatologists will think, but non-rheumatologists are not thinking gout. And gout is getting commoner and commoner and commoner in such a way that quite a few of us in this room will have an episode of gout-related issues sometime in our lifetimes, because we are living the king's lifestyle nowadays. In terms of DECT, I think I will skip this because it has been covered. The other place where DECT is useful is that if you look at an X-ray and if there is a gout erosion, once an erosion, always an erosion. So every time they go to different scan centers, they look at the X-ray, they say, oh, gout, gout, gout. No, well, maybe the gout is treated. There are no crystals left anymore. The erosion stays, but the crystals are gone. This is one of the places where DECT will be helpful. The other place which you have to be careful about is the unilateral monoarthritis, is the calcific tendinosis, right? Like this one. This is not CPPD, this is not gout, this is the calcium tendinosis. And again, my predecessor spoke about this very eloquently. So this is monoarthritis, but it generally is bursitis actually, because it inflammation of the bursa is much worse than the joint itself. So it will feel like joint is horrible. It's very painful process. Actually, it is a self-limiting process. It will go away, but it's so painful that people want to do something about it. And then there must be another lecture on this because it can be aspirated. But whether you like aspirating or not, if you see this, please put a needle here in the bursa and inject steroids. At least the patient will sleep well and it will slowly go away. Now there is inflammatory monoarthritis. This is a very atypical presentation of rheumatoid arthritis with a large geode which is enhancing post-contrast. So this is atypical, but they can also happen in terms of monoarthritis where the inflammatory component is bad. The other monoarthritis mimickers, I don't think I can go through this very much in the 1 minute, but the synovial process monoarthritis, right? 18-year-old hip pain, worsening pain, no sports. So right hip, there is worsening, there is joint space loss, but the density is slowly going away. And then you look at it very carefully, there is scalloping here, there is sclerosis here, there is scalloping there, but there is no calcification in the joint. Immediately you should think about what else is going on in this patient that is causing external pressure on the bone and scalloping. And then when you do the MR, the bone scan was also very hot here. So infection maybe, but this turned out to be PVNS. So PVNS is the other thing that you want to think about if it is not infected to exclude in monoarthritis. And I can stop there. This is also an ultrasound demonstrating synovial proliferation like Cisplatin. Sometimes it can have edema as well, very much like infection, but this turned out to be PVNS, okay? This is actually transient osteoporosis of the hip, but it could mimic like that as well because there is a lot of pain, there is fluid. The key thing is the edges are really clear and there is no edema on the other side. And because I am the moderator, I don't want to take more time, but I'll show you, like in this 2 months later, this guy is getting better. This is, of course, osteomyelitis and arthritis, septic arthritis. Septic arthritis, the other side of the joint is also involved, and it's very irregular on T1 images, the articular process. So you can tell the difference between that even at the stop point. So I will probably stop there. This is a nice case where actually it was a trauma. The truck guy fell, well, missed his step, and then ultimately patient had infection in the hip. So this is a possibility that a trauma can get to the infection in a particular hip. So just because somebody has trauma and fallen off, don't keep washing it off as trauma, trauma, trauma. If there is clinically, they're worried about infection, put a needle in and aspirate, and that'll be it. So with that, I stop. Thank you very much. Let me see who is the next speaker. Right. Next, I would like to call on Dr. Takaishi Fukuda. Now, very interestingly enough, I actually wrote a paper with him a couple of years ago. This is the first time I'm meeting him, and I was looking at him and say, hey, that name rings a bell, and that's how it is. So he is a very prolific writer, and he writes very well. That is my introduction to him. He's an assistant professor in Department of Radiology in Ikai University School of Medicine in Tokyo, Japan. He's interested in musculoskeletal imaging. He's a secretary of the AMS, deputy editor of the Journal of Investigative Medicine, and editorial board member of Skeletal Radiology. Thank you. I think it will settle. Let us see. Yeah.
Thank you very much, Girish. This is first time to meet him. So I really appreciate the invitation and accept my talk. And I'm going to talk about the psoriatic arthritis. And let me start with the reason why we should care about the psoriatic arthritis first. So this is a chronic inflammatory disease associated with the skin disease psoriasis, and it occurs 10 to 30% of psoriasis patients. It predominantly involves peripheral joints, but may have actual involvement, and it belongs to the peripheral spondyloarthritis. And so there are several reasons why we should care about the psoriatic arthritis. So first of all, early diagnosis is very important. So diagnosis delay of merely 6 months is associated with worse radiographic and functional outcome. But diagnosing PSA is sometimes very challenging. So we don't have a single confirmatory test, especially we don't have a disease-specific autoantibody like ACPA in rheumatoid, and we don't have a diagnostic criteria. And importantly, about 20 to 25% of patients experience joint symptom before or simultaneously with skin involvement. So psoriasis may be absent at the onset of arthritis. And furthermore, clinical examination may underestimate the disease. Instead, imaging like ultrasound and MRI can reveal clinically occult inflammation, and it can identify distribution and target tissue, which is very helpful to suspect and also diagnosing PSA. So in summary, we may be the first to recognize PSA. So this is important for us to be familiar with the imaging feature. But before moving on the imaging feature, I would like to talk about the target tissue in psoriatic arthritis. So in inflammatory arthritis, already mentioned by other lecturers, the inflammatory lesions comes first, followed by structural changes. So let's begin by looking at the inflammation. And the target tissue is clearly appreciated when you look at the large joints like knee joints. So in typical case, in rheumatoid arthritis, you can see the prominent enhancement within the joints, which is reflecting the synovitis. And we know that the synovium is the primary target tissue in the rheumatoid arthritis. In psoriatic arthritis, however, you can see the abnormal enhancement at the attachment sites of the tendon. This is reflecting the enthesitis, and the enthesis is considered as a primary target tissue in psoriatic arthritis. But when I say enthesis, actually we have two types of enthesis in our body. One is a fibrocartilaginous enthesis, which is the dominant one, and the other one is a fibrous enthesis. And the fibrocartilage enthesis is usually located near the joints, and actually this is the true target enthesis in psoriatic arthritis. So some might describe the inflammation in psoriatic arthritis as a fibrocartilage inflammation rather than enthesitis, because fibrous enthesis is not usually involved. And fibrocartilaginous enthesis is further divided into classical and functional, which I will explain with the sagittal illustration of the finger joint. So classical enthesis is the sites where the ligament or tendon attached to the bone, near the joint. And histologically, there is a fiber cartilage to handle the strong tensile stress. Because classical enthesis is near the joint, when the joint is moved, usually tendon or ligament experience friction against the bone, and that is the functional enthesis. And again, there is a fiber cartilage to alleviate the various friction stress. And extensor tendon usually fuse with the joint capsule. So there is a synovium closely related with the functional enthesis and classical enthesis. And these close relationship is known as a synovio-enthesial complex. This is very important structure for the smooth joint movement while protecting the tissue. But at the same time, this is one of the reasons why enthesitis can easily cause synovitis. It can easily spread to the synovium. So regardless of the difference in primary target tissue, you will see the capsular synovitis in both type of arthritis. But in psoriatic arthritis, including the enthesitis, will make a little bit different pattern of inflammation. So let's look at these changes. So inflammation through the synovio-enthesial complex leads to the capsular synovitis. And along the flexor tendon, there is a functional enthesis between the pili and the flexor tendon because there will be a friction between them. So that is contribute to flexor tendon synovitis. And of course, pili itself can become inflamed. On dorsal side, extensor peritendinitis is commonly seen, and functional enthesitis, where the tendon experiences friction, it causes a functional enthesitis and produces a prominent inflammation. And of course, enthesitis can involve the joint capsule attachment and the collateral ligament enthesis. And together, these inflammation become extensive and extend beyond the joints and appear as a periarticular inflammation, which is a very characteristic inflammatory pattern of psoriatic arthritis. So you will see capsular synovitis in rheumatoid arthritis and psoriatic arthritis, both type of arthritis, but typical case leaves you a different impression. So in rheumatoid arthritis, the enhancement is within the joint. But usually in psoriatic arthritis, joint capsular synovitis is accompanied by periarticular inflammation in the subcutaneous areas. So it looks like pretty stronger. In my institution, we use the iodine mapping from a dual energy CT to evaluate the peripheral arthritis, and it also successfully delineates the characteristic inflammation difference between them. So again, in rheumatoid arthritis case, you can see enhancement within the joints, but in psoriatic arthritis case, you can see the enhancement in subcutaneous areas, which is reflecting the periarticular inflammation. So flexor tendon synovitis can be seen in psoriatic arthritis, but it can accompanied by a pili inflammation. So on the actual image of at the metacarpal level, you can see a circumferential enhancement surrounding the flexor tendon, which is reflecting the flexor tendon synovitis. But when you look at the MCP joint level, you can see abnormally thickened and also enhanced pili structure. That is a pili inflammation due to a functional enthesitis. So this dual energy CT image shows multiple flexor tendon synovitis, but when you look at the shape of the enhancement, it is like a U shape or semicircular shape, which is consistent with the shape of the pili itself. So it highly likely suggesting that a pili inflammation due to a functional enthesitis. So another functional enthesitis related to the tendon is the extensor peritendinitis. And at the MCP joint level, the friction areas of extensor tendon against the bone slightly shifted proximal when the joint is extended. So the typical finding is the swelling and enhancement slightly proximal to the MCP joints. And you can see extensive peritendinitis in PIP joints and also a DIP joints. So you can see also a bone marrow edema in any type of inflammatory arthritis, but in rheumatoid arthritis case, usually bone marrow edema is located near the bare areas, which likely reflecting the direct spread of a synovial inflammation. But in psoriatic arthritis case, bone marrow edema is considered to originate from enthesis and easily spread to the diaphysis. So in psoriatic arthritis case, bone marrow edema tend to become prominent, involving the mid shaft of the phalangeal bone. And this strong bone marrow edema is not so frequently seen in rheumatoid arthritis. So importantly, psoriatic arthritis have a characteristic distribution pattern. One of them is involvement of DIP joints, and it is a strong differentiating factor between rheumatoid and psoriatic arthritis. And the other one is involving the multiple joints in a single finger. And when the inflammation becomes extensive with involving the multiple joints in a single finger, it results in dactylitis or sausage digit. The reported prevalence varies among the studies, but it is considered as a hallmark of PSA. So I would like to explain why this is considered as a hallmark with imaging. So dactylitis on MR shows that diffuse fusiform swelling of the finger with enhancement of the entire digit, including capsular synovitis, extensor peritendinitis, flexor tenosynovitis, as well as periarticular inflammation. So as I mentioned before, these periarticular inflammation is created by multiple enthesitis. And one paper suggests that multiple inflammation of the enthesial structure required to create the dactylitis. So in other words, the dactylitis is an imaging finding which strongly suggests the enthesitis underlie the inflammatory process. So dactylitis is related to the enthesitis disease like PSA. So once you've got to understand about the inflammatory lesion, it is much easier to understand the structural change which results as which is a result of the inflammation. So enthesitis at the joint capsule or collateral ligament which inserts slightly away from the joint surface leads to a periarticular bone proliferation. And synovitis can cause the erosion at the bare area, and coexistence of the bone proliferation and bone erosion will create the characteristic structure change of PSA. And frequently these lesions may have a fluffy margin, which likely suggests that concurrent bone proliferation and erosion bone remodeling. So it is destroying with making the new bone. So it looks like a little bit like this. So in this case, you can see a severe joint deformity in the DIP joints, which reflect the DIP dominant distribution in this patient. And you can see a typical fluffy margin of the bone erosion and bone proliferation, which is strongly suggests the PSA as a diagnosis. And the DIP joints of the second finger, you can see the joint deformity, which is in the process of penicillin cup deformity, not fully developed. Once it fully developed, it looks like this case. So this penicillin cup deformity is also a very characteristic structural change for the PSA diagnosis. So I would like to move on to the final section, which highlight the potential new role of radiologist, which is predicting the progression to psoriatic arthritis. So similar to rheumatoid arthritis, psoriatic arthritis has a preclinical stage. So European League of the Rheumatology recently divided this period into two at risk and subclinical PSA. And at-risk stage include the patients with psoriasis who have the risk factor for developing arthritis. So risk factors are like a family history of PSA, nail disease, obesity, and so on. It may last many years to develop a psoriatic arthritis. And the next stage is a subclinical PSA, and where the patients develop arthralgia, with or without subclinical inflammation. And subclinical inflammation is the inflammation detected only by imaging, like ultrasound and MRI. And this stage is much closer to the onset of the arthritis, typically within 1 to 3 years. And recently, there have been growing interest in subclinical inflammation because it may suggest the future development of a psoriatic arthritis. So one previous paper suggests that the psoriasis with the subclinical inflammation on MR had a 55% risk of developing PSA, compared with only 15% in those without MR abnormality. So in other words, MRI may identify a subgroup of patients at particularly high risk of progression to PSA. But we know that the primary target tissue is enthesis. So subclinical inflammation, which may be a very subtle abnormality, starts at the enthesis. But tendon enthesis is a short T2 tissue, where the subtle abnormality may remain invisible on conventional MRI. So as you can see, on the conventional T2 weighted image, the Achilles tendon enthesis does not have any signal. It is completely dark. So the subtle abnormality may not visible with this sequence. But fortunately, ultra-short TE sequence or UTE MRI enables signal acquisition from short T2 tissue. So even the healthy Achilles tendon enthesis can generate some signal at the enthesis. And UTE subtraction image can further highlight the short T2 structure like enthesis. And one of the fascinating features of the UTE sequence is a quantitative assessment. In particular, by component analysis allows to acquire separately the short T2 star value, which is representing the bound water linked to collagen integrity, and long T2 star, which represent free water, which is usually reflecting the necrosis, degeneration, or vascularity. And we consider that the subtle abnormality like a subclinical inflammation may affect the collagen integrity first and affect the T2 star values before the overt signal abnormality become visible on conventional MRI. To test this hypothesis, we enrolled the psoriasis and the asymptomatic PSA patients, which both may have a subclinical inflammation, can be detected by imaging without any symptom, and healthy control, and compare their UTE by component biomarkers, and also conventional MR signal ratio of the Achilles tendon with using the muscle signal as a reference on T2 and SDIR. And actually this is so we try to see that UTE can sensitively detect subclinical inflammation, and this is a preliminary results with a relatively small number of patients, but you can see the short T2 star value is significantly higher in psoriasis group compared with in control group, whereas the other UTE biomarkers and MR signal ratio on conventional sequence does not show the difference between the two groups. As you can see, in these two cases, so the upper case is a healthy volunteer and the lower one is a psoriasis group, and you can see the both Achilles tendon enthesis looks normal on conventional sequence, but subtraction UTE sequence demonstrate more prominent signal in the enthesis in the psoriasis group, which may reflecting the short T2 star value, increased short T2 star value. So this is my take-home point. So we radiologists may be the first to recognize PSA, and the enthesis and synovial enthesial complex are central to PSA pathogenesis. And there are several imaging findings which favor the psoriatic arthritis as a diagnosis. Periarticular inflammation, DIP dominant distribution, dactylitis, and periarticular bone proliferation, especially with a fluffy margin. Subclinical inflammation may identify patients at risk of developing PSA, and UTE may reveal subtle enthesial abnormality invisible on conventional MRI. Thank you very much for your attention.
Thank you, Dr. Kakuda. Anybody else has any questions? This is a good time to ask. Maybe you want to do. Otherwise, all the speakers will be available in front of the podium, and they can come out and talk about this.
So are there any questions? Dr. Lynch? So if a patient is sent to us with a clinical diagnosis of seronegative RA for ankle ultrasound, and we find tibialis posterior tenosynovitis, and there is associated thickening of tibial attachment of flexor retinaculum with positive power Doppler signal, is it okay to label it as the active enthesitis and maybe raise the possibility of psoriatic or any other peripheral spondyloarthritis? Sir, a patient with clinical diagnosis of seronegative RA sent for ankle ultrasound and we find tibialis posterior tenosynovitis with associated thickening of tibial attachment of flexor retinaculum showing positive power Doppler signal. Is it okay to label it as active enthesitis and maybe raise the possibility of peripheral SPA?
Yeah, from your question, yeah, I think it's one of the potential is one of the functional enthesitis. So the filial can have a functional enthesitis when have a friction against the retina and also run against the bone. These areas is pretty typical for a functional enthesitis. So you may suggest that the possibility of the spondyloid violation.
Thank you, Takanashi, for a lovely lecture and very clearly explained. Is there any difference between the enthesitis you see with spondyloarthropathy, like big joint enthesitis with spondyloarthropathy and psoriatic arthropathy?
Well, it's I think they share the imaging features, so basically it's the same. But ankylosing spondylitis, which is classified as axial spondyloarthritis, can have a hip joint involvement in the involved the peripheral. So I do not think they share the joints, but finding is just similar.
One thing to add is that when there is one established diagnosis, we should generally stick with that. So if we are seeing something else, it may be an atypical presentation of the same diagnosis. If you're really thinking it's enthesitis and it is in the same location, then we think. But if it's another location enthesitis, then start thinking about other diagnoses. So here I still think some version of any other questions? Yes. Once again.
Thank you, sir. I have one question. I just wanted to know what is your experience with monoarticular psoriatic arthritis? Have you come across cases and if they are like really difficult, patients are being treated as TB capsulitis. I've come across many patients where I have had to change the diagnosis, stop their TB treatment, and I ended up doing biopsy for those cases. So are there any emerging markers, any pointers that could actually favor the diagnosis of pediatric over TB?
So, is it for you? Okay. So, I mean, if you look at the dactylitis, so yeah, always we should exclude the infection too. So, I always suggest that first exclude infection, and after that, the potential another diagnosis is peripheral spondyloarthritis. Yes, and with the clinical correlation, yes, everything.
Thank you all. We know that I've exceeded my time by 20 times, so I should stop now. Thank you very much. Any further questions? We're all here. We can come back one-to-one. But I think the next session has to start. Thank you so much.
So thank you, amazing speakers, for a very excellent, elaborative, pictorial, comprehensive arthritis imaging update. And I would like to thank all speakers and importantly our moderator, Dr. Girish, for such an engaging session. So we are moving on to the next session, pediatric MSK imaging. Without further ado, I would like to invite the moderator of the next session, Dr. Kushaljit Singh Sodhi. Sir, we invite you for the moderation of the next session. He needs actually no introduction. Can you please display his slide? Yeah. So Dr. Kushaljit Singh, he is a professor in PGI Chandigarh. His areas of interest are pediatric radiology, neonatal ultrasound, and oncoimaging. He has a lot of achievements with his due. He has more than 280 publications, 28 book chapters, and 200 invited lectures. He is a vice president of AOSPR and president-elect of Indian Society of Pediatric Radiology, former professor of University of Washington, national coordinator for IRI education program, IRF, and editor of Neonatal Ultrasound Journal also. He has many awards and orations, and VP Lakhanpal Gold Medal. So over to you. We welcome you, sir.
Thank you, ma'am, for the introduction, and a very warm welcome to all of you in this focus session on pediatric MSK imaging. So in the next 75 minutes, to be exact, we're going to cover the entire spectrum, going from pediatric metabolic bone disorders to limping gait, skeletal dysplasias, growth abnormalities, and of course, to top it all, pediatric MSK tumors. I request to all the speakers, including hopefully myself as well, that we have less time in this particular session, that is 15 minutes per speakers. So you will get a first bell at, I think, 2 minutes before the session, the talk ends, right? And maybe we can reserve the questions for the end if there is time, because we need to have a film reading session of the quiz at 5:30. We're a bit short on time. So without much ado, I would like to invite and welcome our esteemed chairpersons. In fact, both are teacher of teachers. I would like to start with the biggest or the greatest teacher of teachers, the legend, Dr. Harsha Shah, sir. Please give a big round of applause for sir. He absolutely needs no introduction. He is the local host. In fact, he's been organizing more conferences than I can imagine. And along with him, another is very esteemed chairperson, Dr. Amarnath sir, who is the past president of IRA. Thank you, sir. So our first speaker of this pediatric MSK session, who shall be speaking on imaging metabolic bone disorders, is none other than Dr. Tarika Salama from Indonesia. Are you here? Okay, great. So she is the medical staff of Musculoskeletal Division at Department of Radiology, Dr. Sipto Mangokusumo. I'm sorry if I'm reading it wrong. Jakarta, Indonesia. Her areas of interest are musculoskeletal tumors and pediatric MSK imaging. Over to you, ma'am.
Okay, thank you for your kind introduction, Dr. Kusaljit. In this session, I will talk about imaging of pediatric metabolic bone disease, patterns, pitfalls, and pearls. Actually, this is just like reinforcing what we all have known from our training. Metabolic bone disease is a diverse group of diseases that diffusely affect the mass or structure of bones by external process, and it can be caused by genetic disorders, nutritional deficiency, and acquired condition. General radiologic appearance is increased or decreased bone density, and it can cause deformity because of remodeling and severely weakened bone. We can divide it into primary and secondary metabolic bone disease. The primary is hypophosphatasia and X-linked hypophosphatemic rickets and osteogenesis imperfecta. And secondary, it ranges from endocrine disorders and also neuromuscular disorders, connective tissue disorders, gastrointestinal disorder, and also hemato-oncologic renal disorders, nutritional deprivation, and medication. Due to time constraint, I will focus into rickets, osteogenesis imperfecta, and also nutritional deprivation as in scurvy. Imaging modalities we can use, the main imaging modality is radiography using skeletal survey, and for evaluation of bone density, we can use the DXA and also QCT. And if we want to see about the bone marrow, and also we want to evaluate the growth plate more comprehensively, we can use MRI. This is the practice guideline from American College of Radiology and Society of Pediatric Radiology regarding the complete skeletal survey in pediatric population. So we have to see the appendicular skeleton in AP or PA projection in the forearms and humerus, and also hands and femurs and lower legs and also feet. And the axial skeleton, we need the thoracic radiology in AP lateral and main right and left oblique. So we can see the ribs and also the upper thoracic, the thoracic and upper lumbar spine. And then we need the pelvic AP and also the lateral lumbosacral spine and lateral cervical spine, and also frontal and lateral skull. So the first one is rickets. It's caused by incomplete mineralization due to lack of calcium salt in osteoid. So in children, we see that it's affecting the growth plate, and in adults, it's affecting the cortical and trabecular zone. It is also involves vitamin D, calcium, and phosphorus metabolism. Here we can see that the most prominent site is the site of rapid growth. So we can see there's involvement of knee, distal tibia, distal humerus, and also the proximal of radius ulna and the anterior of ribs. We can see that there's diffusely decreased bone density, and also we can see that the facial plate is widening, and also we can see that there's a bowing of the femur and also the tibia and fibula. And in thoracic radiology, PA, we can see that there's a widening of the anterior end of the ribs, which is, we call that this is a rachitic rosary. The impaired apoptosis of hypertrophic chondrocyte in metaphyseal site of growth plate due to failure of mineralization and also disorganized chondrocyte growth and hypophosphatemia can cause changes in the growth plate, and also we can see that there's widening of the growth plate, and then we can see cupping and also fraying of the growth plate of the metaphyseal side of the growth plate, as we see in rickets patient, especially at the end of the radius and ulna. The second one is osteogenesis imperfecta. There's a type of osteogenesis imperfecta ranging from the type 1, which is very mild, type 2 usually literal in perinatal period, and type 3, this is the most severe that can be born alive, but it causes the progressive deforming form of OI, and also the type 4 is moderately severe. Here we can always distinguish the osteogenesis imperfecta from non-accidental injuries, because a patient can came to us with sign of fractures, and also some fractures may be healed. So the pitfalls is non-accidental injury. So it is important that we knew the clinical context, and also we knew where is the like we can see the non-accidental injuries is usually has some pattern like probable and also possible non-accidental injuries, and also like metaphyseal corneal fracture. So it could be caused by non-accidental injury. DXA is useful in diagnosing children with milder form of osteogenesis imperfecta, and in atypical cases, especially in infant with unexplained fracture, we can use QCT to evaluate the bone density. Bone fragility usually decreases with increasing age. So there might be osteogenesis imperfecta patient we just stop to have fracture after the puberty. In head, neck, and spine, we can see the basilar invagination, and then we can also see the Wormian bone. If the Wormian bone is not evident at the plain film, then we can see it in the CT scan. And CT scan we can also use to see the basilar invagination. In the vertebra, usually there's kyphoscoliosis of the thoracal and lumbar vertebra. And we can see that as in this patient, like all of the vertebra is compressed, giving the appearance of vertebra plana. As it is compression due to decreased bone density, we can see that the compression is like a codfish vertebra, and also we can see the plateau spondyli if the compression is very severe, and we can see pectus carinatum or excavatum. We can also see decreased bone density or severe osteoporosis, and the bones may be deformed and gracile or overtubulated. We can also see cortical thinning, and also if there's fracture, as in this patient, and there's some healing, so there's we can see there's hyperplastic or exuberant callus formation. And we can also see that there's pseudoarthrosis of the fracture site. In pelvis, we can see that there's acetabular protrusion and also coxavara, and also we can see that there's a shepherd crook deformity of the proximal femur due to multiple fractures, and also we can see here bowing in the tibia and also in the fibula. For nutritional deficiency, one type of metabolic bone disease is scurvy. This is nutritional deficiency of vitamin C causing abnormal collagen synthesis. Usually there's typical MSK manifestation in 80% of cases. Here we can see decrease and disorganized cartilage proliferation causing irregularity of the metaphyseal site of the growth plate. And then we can see that there's sclerotic zone of provisional calcification, or what we call Frankel line, and also accumulation of hemorrhage along the Frankel line, which is called Trommerfeld zone. We can see as lucency adjacent to the Frankel line. And then we can see the peripheral extension of the zone of extension of the zone of calcification here. We can see that it is causing the appearance of Pelken spur. What we can see here also in this image is there's prominent soft tissue mass and also some calcification. So the pitfalls is we have to see and we have to differentiate between scurvy and also the injury of the growth plate, especially the type 1, Salter-Harris type 1, and also soft tissue mass, because sometimes we can see clearly the thickening of the soft tissue and also some solid periosteal reaction caused by the hemorrhage. This patient underwent MRI because of suspected soft tissue mass, and then we can see in T1 weighted image, we can see that there's a hyperintense lesion in the soft tissue, which is still hyperintense on T2 and on T2 fat set, and we can see that the distribution of the lesion is same as the soft tissue mass found in the radiograph, and we can see that there's also some hemorrhage extending into the growth plate here. So the periosteal elevation in this patient is caused by subperiosteal hemorrhage. Here, take to work message. Metabolic bone disease in pediatric population have a diverse etiology and can be primary or secondary. So we have to know the clinical context, and we have also know what is the radiology pathological context of this patient. Radiography, which is skeletal survey, is primary imaging modality for diagnosing metabolic bone disease, and also we can use other modality to evaluate the bone density of the patient. And then knowledge of imaging findings of common pediatric metabolic bone disease is important for diagnosis. I think that's all. Thank you for your attention.
First of all, for speaking on time and taking us through the entire spectrum of metabolic bone diseases in such a short span of time. I would like to take this opportunity to welcome our esteemed chairperson, Dr. Premal Nayak, who is actually not a radiologist, but a very well-known orthopedician and pediatric orthopedic surgeon from Ahmedabad. He's at the Rainbow Hospital, I believe. Welcome, sir. So our next invited speaker happens to be another international invited speaker. Can we have a slide, please? So Dr. Nirmala, who actually did her medical graduation from India, from Rajasthan, and moved to Sri Lanka, Colombo for her MD. She has trained further in Singapore. Her present affiliation is she's a consultant radiologist at Navaloka Hospital and Astoria Central Hospital, Colombo, and areas of interest includes MSK, uroradiology, breast imaging, and general radiology. She's going to take us through a very important topic in our daily practice, that is imaging of pediatric painful hip. Over to you, ma'am.
Thank you. I'll start my lecture. The most common causes of hip pain in children are transient synovitis, irritable hip peaking at 3 to 8 years, septic arthritis any age, peaking at 0 to 6 years, Perthes disease 3 to 12 years, peaking at 5 to 7 years, slipped capital femoral epiphysis early adolescence, usually in obese children. The patient will present with hip pain, limp, fever, history of trauma, and inability to bear weight. Differential diagnosis can be narrowed down according to the age of the child. Young children have difficulty in explaining and localizing from where the pain is coming and communicating. And the problem could be not in the hip, but in the rest of the limb. Now the red flags in hip pain is if the child has an elevated inflammatory markers, right, CRP and ESR, fever, night pain, inability to bear weight, severe restriction of movement, and if has a past history of malignancy. Causes of hip pain can less than 4 years is transient synovitis, osteomyelitis and septic arthritis, juvenile idiopathic arthritis, non-accidental injury, referred pain from the limb. Uncommon are leukemia, eosinophilic granuloma, metastasis, and neuroblastoma. 4 to 10 years is transient synovitis, Perthes, osteomyelitis, septic arthritis. Uncommon is leukemia and Ewing's. 10 to 16 years is slipped capital femoral epiphysis, avulsion injuries, osteomyelitis, septic arthritis, and uncommon again are leukemia, osteoblastoma, Ewing's, and osteosarcoma. Painful hip actually is a pediatric emergency because if it is not treated properly, can be permanent disability. That is why early diagnosis is important and we use imaging for that. If the symptoms are less than 5 days and if the child is not sick, there's absence of fever and inflammatory markers and no history of trauma, we do not do any imaging. The first line of imaging is X-rays, and that is AP, pelvis view and proglateral. Ultrasound is complementary to see the soft tissues, a joint effusion, synovitis. MRI is the gold standard to look for neuropathology, especially when the complications are prolonged, and to see the extent of the disease when the pathology is confirmed. That is in osteomyelitis, septic arthritis, early Perthes, slipped capital femoral epiphysis, stress fractures, tumors. CT is generally used for osteoid osteoma. Now, imaging can be divided into a sick child, not sick child. If it's a sick child, we'll do ultrasound. If there's an effusion, then we think of septic arthritis. If there's no effusion, we go in for other imaging modalities. If the child is not sick, no fever, no trauma, less than 2 years, we will start with X-rays to detect a toddler's fracture or Kohler's disease, and if negative, we will do ultrasound. 2 to 10 years, less than 5 days duration, no imaging, we can also do ultrasound. More than 5 days duration, we will do ultrasound and X-rays. And if it is less than 10 years, you start with X-rays. Even though, this is a proglateral view, even though those are the guidelines, if a child comes with a limp or a painful hip in the hospital where I practice, they will always ask for an X-ray followed by an ultrasound. That's the pediatrician's choice, which may be wrong, but that's what they do it because the patients are anxious. Transient synovitis is an aseptic inflammation of the hip, most likely post-viral. The child can have a post-respiratory tract infection. Boys are affected more than girls. It's a self-limiting disease. It is treated with rest and analgesics, and there is improvement within 24 to 48 hours. Most common cause of hip pain under 10 years of age. Imaging is not necessary, but ultrasound is confirmed. Ultrasound is requested to confirm a joint effusion. If the child is really sick, as I mentioned earlier, then you go in for septic, then it is septic arthritis. Transient synovitis can have recurrence. Very rarely we do MRI, that is just to see whether there is bone edema or not. This is a picture of ultrasound imaging of transient synovitis. Then we come into septic arthritis. Its inflammation is bacterial and is mostly caused by Staph aureus. Children are severely ill with severe pain. Ultrasound, we can see a joint effusion and a thickened synovium. And we do clinical profile to look for increased inflammatory markers. Absence of a joint effusion excludes the septic arthritis. X-ray may be needed for follow-up. And later in the disease, there can be joint space narrowing and osteolysis will be visible. If we do MRI, we can see a joint effusion, thick enhancing synovium, bone marrow edema, adjacent soft tissue edema, and cartilage destruction. It's a management emergency. Next we come into Leccarve-Perthes disease. It is avascular necrosis of the proximal femoral epiphysis. Boys are 5 times more affected than girls, typically between 5 and 8 years. Yeah, it is a younger age group than the capital femoral epiphysis. It can occur bilaterally, but is usually asymmetric. Now the early X-rays will be normal. MRI detects avascular necrosis before the radiographic findings are there. There's subtle increase femoral head density and flattening. Sclerosis and subchondral fractures may develop. You will see the double line sign in an MRI. With prolonged ischemia and necrosis, the necrotic bone has a signal intensity that is fluid, low on T1 and high on T2. And when fibrosis sets in, there will be sclerosis and it will show low on T1 and low on T2. There can be a joint effusion, there can be cartilaginous thinning, instability with fragmentation of the femoral head and eventually collapse. These are some images to show Perthes disease. And ultimately, as I mentioned, with the destruction of the femoral head, you can get a short, broad column, the coxa magna deformity. The differential diagnoses are secondary avascular necrosis secondary to steroid therapy, sickle cell anemia, and a complication of hip dysplasia, Mears dysplasia, and multiple epiphyseal dysplasia. Slipped capital femoral epiphysis is at a high age group and is a type 1 Salter-Harris fracture, common in boys and in obese children, 10 to 16 years, bilateral in 1/3 of cases. Generally, the epiphysis slips posteriorly, sometimes to a lesser extent medially. Best seen in the front-lateral view. Obesity and endocrine factors are predisposition. Avascular necrosis of the femoral head is a potential complication. And you can see this. We use this Strethoven's line and the Klein sign, which when you draw a line on top of the femoral head, it tangentially it cuts the lateral capital femoral epiphysis. And in a slipped one, it does not. Juvenile idiopathic arthritis is another cause of hip pain. It can have systemic symptoms, and if present, we call it Still's disease. It begins as a tenosynovitis, later progresses to bone edema, periostitis, osteoporosis, and growth disturbances. In the later stages, you can get slightly large epiphysis and accelerated bone maturation. Juvenile idiopathic arthritis, of course, X-rays are useful, ultrasound and MRI, and I have outlined them here. I will run through it because it's only 15 minutes. Sometimes we can use gadolinium enhancement to show active synovitis. There will be florid enhancement after contrast. Osteomyelitis is a relatively common severe condition in children, most frequently in children under the age of 5 years. It's non-specific presentation with fever, and in infants there will be failure to thrive, heterogeneous in origin and may follow a previous respiratory tract infection. Most common pathogen is Staph aureus. Imaging, radiographers originally may be normal. In 7 to 10 days, lytic changes and periosteal reaction can occur. Ultrasound can be useful in subperiosteal abscess formation. MRI is the imaging of choice because it will show bone marrow edema, cortical destruction, soft tissue abscesses, joint involvement, and sensitivity exceeds 90%. Infants and children with a growth plate, the growth plate does not act as a barrier and the infection can spread across the joint. And in children with osteomyelitis, you can also have concomitant septic arthritis. You can see florid enhancement in the MRI pictures. Next is Brody's abscess. It's a subtype of osteomyelitis which is typically seen in children. Subacute osteomyelitis with intraosseous abscess formation. Femur and inflammatory markers may be absent. It is most common in the proximal and the distal tibial metaphysis and in the femur. The only complaint is pain. This is located in the metaphysis of the long bones and may occasionally be located in the epiphysis in young children. In X-ray, it's a sharply defined oval lytic lesion which is seen with or without a sclerotic margin and is parallel to the long axis of the long bone. And in MRI, you will see a lesion which is hyperintense in T2 and a penumbra sign. A joint diffusion, minimal edema in the surrounding tissue is possible. This is a typical appearance of a Brody's abscess. Avulsion injuries around the hip joint. These are in a later age group in adolescent children who do sports injuries. As the tendons are stronger and the apophyses in young children are strong, muscle contraction can cause apophyseal avulsion injuries. Iliac crest. These are the sites of the avulsion: anterior abdominal muscle walls, anterior superior iliac spine, tensor fascia lata and sartorius, anterior inferior iliac spine, the straight head of rectus femoris, greater trochanter gluteus medius and gluteus minimus, lesser trochanter iliopsoas, ischial tuberosity is the hamstrings, and in the inferior pubic ramus and the body, the thigh adductors. And these are some of the pictures for the avulsion injuries around the hip. Next we come to osteoid osteoma. Osteoid osteoma is a benign tumor with an extensive bone reaction which causes severe bone pain, and it's commonly occurring at night, and it is a relatively common tumor at the cortex of the femoral head. Now the plain X-rays may show the nidus, even the CT can show the nidus, but nuclear medicine will definitely show the nidus. In MRI, there will be aggressive periosteal reaction, and a person can think that this is an aggressive tumor and not a benign bone tumor. So you have to be careful if you use MRI to detect osteoid osteoma. Other causes of painful hip are eosinophilic granuloma, toddler's fractures, which is one of the causes, which is a minimal displaced spiral fracture of the tibia. Then there is non-accidental injury, mesenteric arteritis, and I must mention that the congenital dislocation of hip is not a painful condition. You can see in this non-accidental injury, corner fractures, again spiral fracture of the non-accidental injury, and the toddler's fractures. Thank you very much for inviting me for these lectures. I must thank the association, my parents and my teachers for the support, and my family for the support they have given me. Thank you.
Thank you, Dr. Nirmala, for taking us through the big spectrum of the child with painful hip. And thank you for speaking on time once again. So we have 1 minute. If there are any questions, otherwise I'm going to indulge, since we have a very eminent pediatric orthopedic surgeon. Are there any questions for Nirmala, or should I bother Dr. Premal Naik here? Sir, I have a very practical question since we have you in our audience now. So which amongst the imaging findings, when you are dealing with a child with a painful pediatric hip, really you want to know the findings immediately, like they're very urgent and important to you, and how does that help you change your management decision?
Thank you for the invitation. Many of you may know or may not know, Ahmed and I are very close friends and a classmate. We shared bench from first MBBS. I really miss him. Coming to the question, pediatric hip, when it is a painful, there are 3-4 conditions, as madam has mentioned all of them. And I think when the X-ray does not clinch a diagnosis, in X-ray pelvis is the most important diagnosis, but the most important majority of the diagnosis are clinched on a frog lateral X-ray. So we had a study in which we involved few radiologists and an orthopedic surgeon, and when we gave them X-ray, 80% could not diagnose SCFE, that is SCFE or plain X-ray. But the moment you take frog lateral X-ray, you will be able to diagnose. So if you have a painful hip, the first thing is you do pelvic X-ray, you do frog leg lateral, 90% diagnoses are made. Only when you are in doubt, you go for other imaging, and the most common imaging, if it's not an osteoid osteoma, an MRI is of that. Because if you cut the cost, 2,500, I'm from Ahmedabad, so cost is an important thing for us. So if I have to spare patients of some expense, ultrasound, which gives me only synovial and fluid details, but MRI gives me all the details, all including marrow. So if the child is not supposed to require any anesthesia, my choice would be to go for an MRI. How much does the MRI cost? That is variable. As low as just 1,000 rupees more than ultrasound.
So it varies from
it's about
and practice to practice.
About $35 to $45 exactly.
Because we have to pay about 25,000 or 30,000 for an MRI.
Okay, we will not walk that road. That's a different topic altogether. Thank you, sir, for further wisdom.
Okay, next one I will read it. Okay, next one is activity dysplasia. His moderator is going to that's what he is going to talk about. He is now is the president-elect of ASPR. Okay. He is had actually very long degree and qualification in the PhD, FICR and FRCR, and he is now professor at the Department of Radiology, PG Chandigarh, and is a interest pediatric radiology.
नहीं इसके अंदर वो फाइल इज नॉट ओपनिंग.
Okay, he has more than 300 publications, okay, books, and vice president, and he is the visiting professor of the Department of Chemistry, San Luis, and national coordinator for the program.
Thank you.
And editorial board in the neonatal ultrasound, and recently got actually honorary FRCR and honorary member of SPR
All right, thank you, sir. So I requested everybody to finish on time so that I can take some of their time. So I've been asked the most difficult topic to speak on, that is skeletal dysplasias, imaging for diagnosis and prognostication. Just to give you a perspective from where I am standing right now, so there are textbooks on skeletal dysplasia, right? So even then you can't finish the entire topic, but I have to finish in 15 minutes and 14 minutes. So I'm going to be a bit fast. My endeavor is going to take you through the common approach to a child with skeletal dysplasia and take you through the spectrum of the more common imaging findings which we expect as a daily, in our daily practice as a radiologist we should do. And in the end, we hope to take you through some prognostic markers as well. First and foremost, most important, many of the images are of course from the internet. We don't have so many of them seen in our daily practice. So before I go further, I want to apprise you there is a digital library now for skeletal dysplasias. So there are a lot of resources available on the internet and a lot of AI coming up as well. Most of them are not FDA approved. So there are, I know offhand, there are at least 4 studies going on in the United States on skeletal dysplasia using AI to diagnose skeletal dysplasia, but they're yet to get FDA approval for them. So these are online websites and materials which you can log into and take help from if required. Okay. To set the ball rolling, skeletal dysplasias, also termed as osteochondrodysplasias, they're the same thing. Essentially, these occur due to genetic mutations. But remember, their phenotype continues to evolve throughout life. So it is very important to take serial X-rays, right? Not just stop at one X-ray. So we have an International Skeletal Dysplasia Society, which was formed nearly 26, 27 years back, and they go on revising their classification and nosology. The latest one was in 2023, around 2 to 3 years back. But what is important for you to know, and or if I may say, all that you need to know now, that we have nearly 770 different skeletal dysplasias to make our lives even more difficult. Earlier we had 200, then 400, but now we have around 770 different skeletal dysplasias. And we have nearly 500 or 550 genes identified, mapped to them as well. So they have been grouped into 42 distinct groups, out of which 33 are skeletal dysplasias and 9 are dysostosis. What is the key change? That is what you should know, right? As opposed to the previous revisions of the International Skeletal Society or Skeletal Dysplasia Societies, now there is an adoption of a dyadic naming system. That is, you have to pair the diagnosis, the clinical phenotype with a particular gene as well. For example, if you label it as thanatophoric dysplasia, along with it, you have to describe the phenotype, the gene, that is, it is FGFR3 gene related. That is essential change, important component. Another thing which is very important is what is the protocol for skeletal dysplasia. You just cannot diagnose skeletal dysplasia, or it won't be right for you to just rule out skeletal dysplasia based on just doing one pelvic X-ray or maybe a spine X-ray. So there is a minimum guidelines which are established. So by and large, you need this 7 set of X-rays which has to be done for skeletal dysplasia. This is the abbreviated form. This is not the full course of skeletal survey, which actually involves 28 radiographs, but these are 7 set of radiographs: skull epilateral, DL spine epilateral, chest, pelvis, left hand for bone age. Why left hand, anybody? Why do we left hand for bone age? Because the right hand is usually dominant, okay? And of course you do one upper limb and one lower limb, but in case you are dealing with epiphyseal abnormality, in those cases you need to do bilateral limbs, bilateral upper limbs, bilateral lower limbs. So remember, 7 set of radiographs, bare minimum required for skeletal dysplasia surveys. Okay. So as I said, I'm going to take you through how to approach skeletal dysplasia, what do you look for in a child with suspected skeletal dysplasia. So this is a ABC approach by one of the good articles by Amaka Afia. She's the editor incidentally now in pediatric radiology. She's Sheffield's now, earlier trained in Gosh. So she calls it the ABC approach, right? So what do you mean by ABC? Anatomical localization, B for bones, and C is for complications. Due to lack of time, I'm not going to run through all of them. I'm going to show you what is important, right? So what do we mean when I say anatomic location? So luckily for us, we can divide it easily into an axial skeletal or appendicular skeletal, right? So by appendicular skeletal, I mean the limbs, right? Upper limb, lower limbs. And when I say the axial skeletal, skull, chest, and the spine, right? Why this is important is because there are certain group of dysplasias that are predominantly involving the axial skeletal. And there are also a certain group of dysplasias which are predominantly involving the appendicular skeleton, right? So if you can know only a particular axial skeletal is involved, what kind of bones to look for or what kind of diagnosis. And when I'm talking about appendicular skeletal, what exactly has to be assessed for? First, type of bone shortening. Second is location of abnormality, whether it's epiphyseal, metaphyseal or diaphyseal. When I say type of bone shortening, I mean which kind of, is it proximal? So if it is a proximal one, I don't know if it's working or not. Okay, maybe not. So if it is a proximal one, it's called rhizomelia. If it's middle one, mesomelia and acromelia. I use the word RMA just to remember myself, RMA. So this is a child with rhizomelic dwarfism or rhizomelic shortening of the limb. As you can see, this upper limb, there is rhizomelia here. So what is the standard prototype of a child with rhizomelic dwarfism or rhizomelic shortening? Anybody? Which is the most commonest skeletal dysplasia? Come on. Yeah, achondroplasia. Yeah, so this is achondroplasia, right? But there are other causes of rhizomelic shortening as well. This is a long list as well, but you need to know the first two or first 1, 2, 3 more common causes. Similarly, a child with mesomelia now, this was a child with mesomelic dysplasia, but as I said, there are other causes of mesomelic shortening as well. And then, of course, we have acromelia or the distal limb shortening as well, or distal limb shortening. Yeah, diastolic dysplasia in this case, but there are other causes of acromelia as well in child only with skeletal dysplasias group as well, okay? What about bones? So remember 5S. First I said A, B, C. Then in B, I'm saying 5S, okay? Structure, shape, size, sum, and soft tissues. If you can remember this, okay? It's not that tough actually. So what do I mean when I say structure? When I'm calling structure of a bone, what I mean to say simply is the bone density might be increased or it might be decreased. So as you can see on your left hand side, so this is a child with decreased bone density. So this group as a whole can be called osteopenic dysplasias, right? So what is the standard prototype for a child with osteopenic dysplasias? Sorry? Sir, you are teacher of teachers. It's for residents. Come on. Oh, yeah, osteogenesis is imperfect, right? Similarly, increased for sclerosing dysplasias, osteopetrosis, right? Yeah, but there are a lot of entire list of causes of all these entities, whether we are calling osteopenic or sclerosing dysplasias. Similarly, you can have multiple exostosis. So what is the diagnosis in this one? These are all exam spotters for residents. If I'm assuming there are a lot of residents sitting here. So I can take you, if there are 50 or 60 spotters in your exams, you will get at least 2 or 3 are short skeletal dysplasias, and usually, thankfully, they are straightforward. What is this? Diaphyseal ecclesia. Perfect. Similarly, you can have multiple enchondromas as seen here, all ears disease. Shape of the bone is another important thing to look at. You could have flayed metaphyses, stippled epiphyses, flat vertebra or hook-shaped vertebra. I'm going to show you some of the examples. For example, this is a typical flared metaphysis. Oh, the arrow is working perfect. So you can see the flared metaphysis at the distal end of femur, right? So this is a case of Schmidt type metaphyseal dysplasia. So this is how the flared bottom look like. Do not focus on Ananya Pandey here. Come on. This is not the reason to put it here. I just wanted to show how a flared metaphysis is going to look like. So if you remember this bell bottoms now, also probably you will remember this distal end of femur as well. So again, there is a lot of causes of metaphyseal flaring as well. But once you have diagnosed one finding metaphyseal flaring, look for other findings and try to knit the story together, right? Size is another thing amongst the 5S. So you could have abnormalities of size, which may be absolute or relative. So if you have a child with elongation of the distal fibula, as in this case, right? So you have a child, obviously the distal fibula is elongated here, right? So this is one of the features of hypochondroplasia. Similarly, if you have gross limb shortening with body length often below the 3rd or 4th percentile, as in this one, this is campomelic dysplasias. Okay. How much time I have left? 5 minutes. That's it? Oh my God. Okay. So I'm going to rush you through some of the classical findings. These are like spotters once again for the residents. These you should be able to diagnose. But remember, life is not that easy. It's not always white and black. They don't usually come like this. But of course, you need to know the bare minimums, and these are the bare minimums. Okay, here we go. So if you have a child with antero-inferior beaking, when I say beaking, this is what I mean like, or you can have a central beaking. So this is very important. Central beaking or antero-inferior beaking. What the first thing that should come to your mind is? MPS, perfect. But you should know MPS 1, Hurlers or MPS 4. Antero-inferior beaking or a more central beaking. Remember, there can be other couple of causes as well for central beaking, like pseudo-hypochondroplasia as well, but by and large type 4s, you should remember. Similarly, you would have seen this sign, which is described as the chevron sign on different roundabouts, right? So again, you can see rhizomelic shortening, metaphyseal flaring, and inverted V-shaped appearance. This is what a chevron sign looks like in a classical achondroplasia. Remember, achondroplasia is the most common non-lethal dysplasia, and it is the prototype of rhizomelic dwarfism. Similarly, you can have increased space between the third and the fourth digits. So you have this trident hand, again achondroplasia, or you can have this typical short pelvis, round iliacs, shallow acetabulum. Anybody? Champagne glass pelvis, right? Yeah, okay, again achondroplasia. What about this? Long narrow thorax with handlebar clavicles. Remember, long narrow thorax you can see in many entities, including thanatophoric dysplasias as well. But in this particular child, you have classical handlebar clavicles, right? This is Juvin's or asphyxiating thoracic dysplasias. As I said, long narrow thorax can have other causes as well. Oh, this is one of the easiest one, and I'm very happy whenever I see one of these X-rays. Sandwich vertebra. Depends what kind of sandwich you like, egg or chicken or whatever. But if you get spine like this, right? This is like a sandwich vertebral body, and plates are quite dense and sclerotic. So this is a very classical osteopetrosis. You need to be louder, come on. What about stippled appearance? You have bilateral stippled appearance in a child, right? This is again very classical appearance of chondrodysplasia punctata. There are other causes, of course. You can have seen in trisomies, exposure to drugs overdose as well. But remember, chondrodysplasia punctata, bilateral epiphyseals, stippled appearance, right? Coming back to osteopenic dysplasias, multiple fractures, growth arrest lines, wavy ribs, again deformed log bones. This is osteogenesis imperfecta. What about this one? Telephone handle receiver. These used to be telephones in our age, not in your age. Nowadays we have mobile iPhones 18 now coming up, right? Samsung, there are more mobiles. But these used to be our telephone handset earlier, 2-3 decades back or maybe more, right? Apart from that, you can see this is a long narrow thorax. There is platyspondyli, short iliac wings, clover leaf skull. So this makes it thanatophoric dysplasia. Yeah, this is the most commonest lethal skeletal dysplasia. So I have less than 2 minutes. Somebody has to bell, please. Hello? Hello, sir. You need to bell in 2 minutes. No, not for me, for the next one now. Okay. So why does prognostication matters? No, I'm a moderator as well, so I'm doing that role as well. So why is prognostication important in these children? Because you need to predict neonatal survival. It can help you guide pregnancy counseling, plan delivery at a tertiary care center, and estimate the recurrence risk. Again, the most common lethal skeletal dysplasias, top 4, which one? These are the ones we need to know. That's it. We need not remember all, maybe 101 of them out of the total 770. So the 4 top on the list is thanatophoric dysplasias, osteogenesis imperfecta type 2. Remember, there are 8 types, but only the type 2 is considered most lethal, nearly 14%. Achondrogenesis and campomelic dysplasias is quite less seen, but yeah, you need to know, 2%, okay. So a typical thanatophoric dysplastic child I just showed you, and this is a child with achondrogenesis, totally unossified bones, right? Okay, I'm struggling with time here. So there are multiple sonographic predictors of lethality. So when you're doing a neonatal ultrasound or a prenatal ultrasound, actually, some soft indicators which can lead you or guide you to this path of these are going to be lethal skeletal dysplasia. First, a bell-shaped or a narrow thorax. Chest to abdominal circumference is less than 0.6, short ribs, severe femoral shortening. What is that? More than 4 standard deviation below the means. So always remember to measure the femur here. If it's less than 4 standard deviation, that's called severe femoral shortening. Reduced lung volume, one of the most important parameters. So amongst all of them, the strong predictors is severe pulmonary hypoplasia. That is the single most important parameter to note, or which predicts lethality. In fact, if you look at, yeah, okay, my own, yeah, just two more slides, Chairman sir. Yeah. So if you look at the lethal ones, the major cause of death is pulmonary hypoplasia, or the respiratory effect here, or the deficiency here. But in achondroplasia, is craniocervical stenosis, and hypo has almost near life expectancy. So role of advanced imaging in prognostication includes looking at the lung volumes, right? Whether you do an ultrasound or a lung volume. But now the go-to or the standard guidelines internationally is a multidisciplinary approach, which involves the radiologist, neonatologist, maternal fetal medicine, genetist, pediatric orthopedic surgeon, and pediatric pulmonologist as well. So I would like to conclude by saying we need to follow a structured imaging approach, which is integrated with clinical and genetic findings. I'm sorry, due to lack of time, I could not focus on the genetic findings more, but it significantly improves the diagnostic accuracy, and a multidisciplinary collaboration between the radiologists, genetics, orthopedic surgeons, neonatologists, pulmonologists is very essential for optimizing patient outcomes. Thank you so much. I'm going to call the next speaker, just a second. So the next speaker is a very senior radiologist, Dr. Chidambaranathan sir. As we know him, I'm not going to read the whole page, it's like a test book actually, but he's been the past chairman of Indian College of Radiology and Imaging, past president of ISNR, past vice president of ISNR, and he has been the examiner of so many of your teachers and head of the departments.
Yeah, thank you.
Over to you, sir.
Thank you very much. Okay. Thank you very much, Dr. Swadhi. This next 15 minutes, so we are going to say the most important thing. We had in child, we will get some damage occurs particularly in case of facial plate. The facial plate injury occur, maybe injury or maybe some insult can producing growth plate disturbances. Oh, see, there is the areas that growth may be distorted or maybe something related to facial bar can lead to changes. Just let us. So most importantly, radiologists should familiar with this early facial plate injuries. Okay, the learning objectives are today review the normal anatomy and physiological feature of the primary growth plate complex. Okay, growth plate complex, that will be growth plate or maybe facial plate, that epiphysis, metaphysis, and the pathophysiology direct and indirect insult, and to recognize the various imaging pattern of growth disturbances. That is more important for us to get familiarity, to guide the selection of the most appropriate treatment for the particular orthopedic surgeons. So just quickly we'll review the radiological anatomy. So all of you know this, the growth plate complex, that's the end of the long bone, there's the growth plate. It consists of 3 hyaline cartilage. The primary growth plate is almost, look at the blue, there's yellow line, that is a discoid type of areas. And the secondary growth plate is a spherical, that is actually like a greenish, and this superficial articular cartilage will be like maybe pink color of orange color. So this growth plate may be responsible for longitudinal growth plate. There is where the chondrocyte proliferative zone is rapidly grows and contribute the length of the bone. And the second growth plate, that is acrophysis, will respond for the enlargement of the bone and to give the shape to the end of the long bone. So growth plate contain that is be highly cellular, and 75% is chondrocyte, maturing as the epiphyseal line. From the epiphyseal line, from the chondrocyte is mature as the randomly situated, it goes towards actually metaphyseal line. Okay, moves epiphyseal towards metaphysis. Okay, 3 distinct zone of the chondrocyte. That's what first called the reserve zone. In the reserve zone, randomly chondrocytes are present, and within the extracellular matrix, within the collagen matrix, this reserve zone will more highly cellular, and the proliferative zone is they arrange that these cells are more arranged in a linear column. Okay, as rapidly grows and the contribute length of the bone. This is more vital for the growth. And the next one is a hypertrophic zone. The hypertrophic zone is a maturation, degeneration occurs. Where actually zone of provisional zone of calcification occurs. Okay, and this occurs once that occurs, that cellular damage occurs. That is become that area become more avascular due to their cell damage occurs. The death will occur for the cells particular. So that will be zone of provisional zone of calcification occurs. Within the metaphyseal zone, the calcific cartilage become replaced by laminar bone. This is a normal anatomy. And growth plate vascularity will be more supplied by the epiphyseal artery and metaphyseal artery. And the central portion of that epiphysis will be relatively avascular. It's not much vascular, but that's why it is more vulnerable to damage. Okay, so the metaphyseal zone is a vascular loop all periphery. Okay, and the perichondrium will be supplied by the this mainly for the perichondral artery. This is the way normal vascular supply occurs. The growth plate disturbances occurs. What is the two important functions? One is the zonal arrangement. As already mentioned about the chondrocyte cellular function, may be a balance between the chondrocyte proliferation and the proper that cellular death occurs. That is should be in the order. Or otherwise, it is a vascular supply from the adjacent epiphysis and metaphysis may be intact. The two things important. If the function is altered, then producing there is insult occurs. The insult can occur maybe injury to the growth plate by direct insult, or it could be vascular compromise on either side of the growth plate by indirect insult can cause growth plate dysfunctions. Okay, so that leads to a lifelong morbidity, a limb lengthening discrepancy, angular deformity, and or altered biomechanism. So we should be familiar with these entities. Okay, so acute growth plate injury can be divided into a direct or indirect. Direct can be related to trauma, that is direct growth plate injury, or indirectly that's epiphyseal or metaphyseal areas involvement. Less common insult occur this vascular compromise like a secondary to infection, inflammations, radiations, or electrical injuries are related to neoplastic process. They are all quite rare, but most commonly trauma and infection, vascular compromise. So all of you familiar with there is no Salton Harris type. Salton Harris type is type 1 will be exactly the fracture involved exactly at the growth plate level. So the slipped capital epiphysis is one of the classical form. The Salton Harris type 2 will be a metaphyseal fracture with epiphysis and metaphyseal involvement. The group 3 will be exactly at the level of the exactly epiphysis and this is type 4 will be metaphysis epiphyseal involvement, and type 5 will be crush injury of the growth plate. Then another type that is recently the subset started to be 6 and 7, 8 that related to trauma of the perichondrium, or it can be osteochondral fracture, or it could be metaphyseal fracture or avulsion injury of the periosteum. These are all also considered as there is no epiphyseal injuries type. So acute injury, Salton Harris type 4. The 5 will be growth plate exactly at the level that physeal injury occurs. It can be because stressy mechanism, or maybe child having sudden overusing area limb, or maybe severe trauma or mild trivial trauma can producing this type of physeal injury or physeal edema. So the periphyseal edema can lead to that is typically can get some kind of vascular compromise. So it leads to a bridge formation. I'll tell you later how the bridge formation occurs. So infection also can commonly involve that physeal plate involvement. It can be transphyseal. Or maybe linear. Okay, linear any form involve the physeal plate that leads to physeal injury occurs. Okay, so these injuries are any type of type 1 to type 5 or maybe type 4 injury of the exactly metaphyseal involvement secondary to. This lead to a growth plate related to a high that is transphyseal vascularity. It's facilitate. There's increased vascularity occurs. So what is happened? This protein lot of recruitment of osteoprogenitor cells that leads to typically what is called bridge formation. That bridge formation because highly vascular that level is become highly vascular. So it producing a bridge formations. This bridge formation can producing a bone bridge formation or maybe delayed cupping as we see. So any direct growth plate injury producing a bridge formation or delayed cupping formation. So this is a classical example of this kind. This is a case of epiphyseal osteonecrosis and the patient exactly see that areas where the epiphyseal lot of vascularity, transphyseal vascularity increase producing a lot of linear vascular channels at this level. Okay, that prediction of the facial bar. Okay, so the facial bar manifestation can occur anyways. There may be facial widening, or maybe a small cartilage intrusion. Within the facial plate, the cartilage intrusion occurs, producing some kind of bar, or premature closure occur, or maybe facial bridging can occur. This is any form manifestation of facial injury producing this abnormality. So this facial injury can be a epiphyseal level or could be metafacial level. Okay, anything. So it can involve the facial plate and metafacial, or facial plate with metafacial or epiphyseal level. Okay, so if there is a facial interposition, if there is soft tissue, anything, maybe a tendon or maybe a bone, this producing interposition can lead to this involvement of the growth plate, where actually identified as a widened areas. So this can be, this facial plate can be intraosseous facial, interstitial facial, or transfacial, or metafacial, or epiphyseal. There are 4 types there. And see the example of periosseal interposition. In a periosseal interposition occurs, there is a widening of the growth plate initially. Okay, that is, this is a patient having that slightly older, there is X-ray shows there is a periosseal, there is exactly at the level of the periosteum, there is turn of the metafacial periosteum. It lied within the area of the facial injuries. So this one leads to, after some time, what happened? They are producing a facial bar, or maybe premature closure of these areas producing a facial bar. So once a facial bar occurs, there is the longitudinal growth may be vary from the anterior to posterior. There will be angulations occurs. So once this type of injury occurs in the facial bar, there is facial injury that leads to exactly at the facial bar formation. This facial bar formation occurs, the bone becomes fixed at that area. So there is a growth disturbance occurs the medial and anterior and posterior aspect. So there will be not uniform lengthening will not occur. So there is angulation. Okay, there is longitudinal growth will be maybe vary from, look at the areas anteriorly. It is here this is more elongated, and this areas become more shorter. Those shortening and this one will be vary, can occur in these areas. So the sequelative growth plate injury in the epiphyseal origin can lead to, there are 4 manifestations. It can be a fragmented superior secondary ossification center like facial plate like that, or maybe a slowdown of the longitudinal growth. There is a differential longitudinal growth occurs. So not uniform, that this area medial end and lateral end is not uniform. There will be a proximal displacement of the growth plate occurs, or maybe can get bridge formation, or growth plate closure will be, early growth plate closure will be. These all can occur in a injury, or maybe occurs in the growth plate in the epiphyseal origin. So this is a patient having, there is patient having, there is a injury, a normal old MRI, this one you can see that normal areas where there is early edema is there. The patient had a child with the presence of the deformity after 6 months of age, after 6 months of injury. That leads to exactly as I told, there is no deformed secondary ossification center, and there is slow down the longitudinal growth plate, and there is a proximal displacement of the growth plate and abundant ossification center. See, look at the ossificate cartilage will be unossified and become more pronounced. Okay, or it can get a facial bar. So these changes occur in a epiphyseal injury. Epiphyseal and facial injury occurs, this type of facial bar with associated involvement of the secondary ossification center or very overgrowth of the this cartilage. So the growth plate injury occurs in the metafacial origin. If there is metafacial origin, what happened? There is a vascular compromise leads to prolonged survival of the chondrocyte. So what happened? This producing dysfunction of endochondral ossification, producing there is lengthening, and the chondrocyte column will be metafacial. As we go in the metafacial end, that cellular death occurs very quickly. That then will producing, there is a growth plate widening or focal tongue like persistent cartilage, or maybe broad band from the repeated trauma. Here is the example. You can see that this is a 10-year-old person having that a runner overuse syndrome. This producing, there is a metafacial injury leads to widening of the growth plate. First important finding is widening of the growth plate, or indistinct that zone of provisional zone of calcifications, or maybe sometimes subtle irregularity of the linear band. These all occur in the metafacial injury occurs. Okay, or sometimes sclerosis. So any form, anything can occur. Suppose widening may be indistinct margin, or maybe sclerosis, or this can be occur. If there is a bilateral involvement, it can get, okay, if there is sports overuse syndrome. In a case of treatment case like that, no, this patient had, there is a metaphyseal osteonecrosis. Patient after chemotherapy, there is extensive osteonecrosis of the bone. But if we see that area, the metaphyseal area, there is a growth arrest line will be, we can say parallel to the growth line is that parallel to the growth plate areas. You can see there is this patient adding, there is a osteonecrosis at the level of the metaphysis. So what leads to unossified growth plate cartilage. You look at the area as normal growth plate, but this area is unossified growth part cartilage occurs. So the role of imaging, maybe what are the role? So there is accurate mapping, where is the size and anatomy location of the bridging, and how much of percentage at work there is a growth plate involvement is most important for a radiologist. Okay, why? Because the management differs. The management based on the how the anticipated growth to be patient age, the anatomy location, and imaging finding, and how the deformity occurs. So the type of bar could be it can be related to bony facial bar, or it could be an unossified cartilage bar, or it could be a fibrous bar. This can any type of bar. So most important for a radiologist should know the mapping. How the quadrant mapping is important. How much the size of the bar in relation to the cartilage. There is a manual quadrant mapping, but area of the biaxial cartilage and the area of the entire growth. So can be assessed by the anterior, central, and posterior. You can do like a marker, anterior medial, anterolateral, or posterolateral and posterior, any quadrant, which quadrants involved, so they can be mapping can be done. So most important thing, with the facial bar, maybe the size of the bar is most important. What is significance of quadrant mapping? If the facial bar, the medial aspect involvement is a genu varus deformity. You can see that like that. No, there is a facial bar is more involvement. There is a varus deformity. On the other hand, if the facial bar occurs in the distal femur, causing genu valgum deformity. Here the facial bar lead to genu valgum deformity. If the facial bar in the central quadrant, the child become limb shortening occurs. Okay, so the rational treatment will be depends on the size of the bar. If the small bridge will be less than 30% of the total areas affect the central portion of growth plate, patient who are nearing the skeletal maturation, conservative treatment. If there is a bridging formation is more than about medium size, 30 to 50% of the total areas, or more than 2 centimeter growth remaining, so there is a bridge resections. Or if they are more than 50%, epiphyseodesis. Okay, I'll do another one slide. I will finish. The bone lengthening who have the more than 2 centimeter limb discrepancy, as the injury occurs, bone lengthening can be done. Okay, to conclude, injury to any of the 3 components, there may be a facial plate, or epiphyseal or metaphyseal plate, can lead to variety of growth disturbances that have characteristic imaging feature. We have to recognize very early stage of the facial injury, and mapping of how much the size of the bar is most important, and that is crucial for diagnosis. So these imaging features are vital for ultimate goal for timely and appropriate management of the patient. Thank you very much for your attention.
Thank you so much, sir. Our next speaker and the last speaker in this pediatric MSK session is a very good friend of mine, and actually a very sought after speaker. We're lucky to have him here, all the way from London, from the Royal National Orthopedic Hospital, Stanford, London, and actually is the leading authority in bone and soft tissue sarcomas. Right, sir? And he's going to take us through pediatric MSK tumors. I know it's a big task in 10-15 minutes, but over to you, sir.
Thank you. This is the last talk, and I won't impose on you guys too much. Yeah, you had a very busy day. Not much to learn. Yeah, just observe a few points, and I'll tell you as I go along. So I've been given a very vast topic to speak in 15 minutes, and it's just not possible to cover everything. Just note a few points over here. I'm going to talk about bone tumors and soft tissue tumors and the differences in both. Bone tumors usually present in the pediatric with pain, yeah, whereas the soft tissue tumors are usually painless. It's only when the mother, what you call, bathes the child, they can feel a lump. When the pain occurs is usually because of increase in the size of the mass, and then the child usually limps or there is muscle weakness. We'll just look at the bone tumors now. Primary bone tumors most of the lesions you see are usually benign, malignant are very rare, but the key point is under the age of 10, benign bone tumors are rare. So if you see a lesion under the age of 10, you got to be a bit cautious. Either it is infection or it is an aggressive lesion. So you got to be a bit careful under the age of 10 if you see. Most benign bone tumors like osteochondroma, simple bone cyst, all occur after the age of 10. So this is a very useful differentiation. Malignant tumors, the most common are the osteosarcoma and Ewing sarcoma, and they usually occur in the adolescent age group. Bone tumors, characterization, plain film. Okay, so there is a topic for another day, and I hope you guys are well versed with how to assess a bone tumor on plain films. But the key 3 points we look at it is, one is age, second is location, and third is the radiological features. You guys can take a picture of this, not exactly of the picture, look at the reference in the bottom. It's a very lovely article in skeletal radiology, very detailed, so you can have a look at that on how to assess radiologically a bone tumor. Now this is an important slide. Most tumors present as a lytic lesion. We just keep the sclerotic lesions aside. The first impression you got to make is it aggressive or is it non-aggressive? And if it is aggressive, where you got all the radiological features of low margin, periosteal reaction and stuff, think of the age. If the child is under age of 5, the most common diagnosis is osteomyelitis. More than 50% occurs before the age of 5. Then of course you got LCH, and then you got the metastatic neuroblastoma and everything else going down, but the number one diagnosis is osteomyelitis. If it is more than 5 years, think of slightly more aggressive lesion like an osteosarcoma, any one of those bone sarcomas, or a blood disease. If it is a benign appearing lesion, and if it is less than 10 years, think LCH. But if it is more than 10 years, as I said, you got the common benign bone tumors, which could be osteochondroma, fibrous dysplasia, any one of those lesions. Here, the key disease is LCH in a child, which can occur across all age groups, and it mimics, is the greatest mimic. So there are two great mimics of bone lesions. One is fibrous dysplasia, another one is LCH. So LCH can appear benign, LCH can appear aggressive. And the reason I say this is, what the mind does not know, the eyes do not see. So when you see this, you got to have your surgical sieve. Is it congenital? Is it traumatic? Is it infective? Is it inflammatory like rheumatological or LCH? Or is it a tumor? So this is the surgical sieve you got to run through every time you see a bone lesion in a child. Yeah, you always have to, you got a fantastic talk on dysplasias. You got to think, is it a dysplasia? Is it a normal variant? You got to run through the surgical sieve, and then you got to make a plan. So I've been asked to speak on role of MRI. As I said, bone tumors, plain films. Yeah? Never report an MRI of a bone lesion without a plain film available. What do I see on an MRI? 3 things. One is, what are the lesion characteristics? 2 is for staging, the local staging along the horizontal plane and the longitudinal staging, and then of course distant staging to see if there are metastasis, or is it a multicentric lesion or a paracentric lesion. So in this case, signal intensity. 3 sequences. Don't worry about the fancy sequences. T1, T2 and STIR. Yeah, this is your workhorse sequences. Don't worry about all the complex sequences and contrast and everything else. These are the basic sequences you should always have for tumor imaging. And in this case, I was showing you a simple bone cyst. The MRI can look aggressive, but if you look at the plain film, you can make the diagnosis. So what does the MRI actually add over here? It doesn't really add very much. Whereas in the case of this, a young, where the epiphysis is fused, you can see a giant cell tumor. Here the MRI shows a low signal on T2, which is very bland throughout. And this is a very characteristic feature. So if you see a low signal in expansile, subarticular lesion, is usually a giant cell tumor. But remember, I call it a giant cell tumor, but there is not always a diagnosis. It could be giant cell, it could be giant cell rich, it could be osteoclast, it could be a huge number of diagnoses along the line. But the 2 points you got to make is, one, is it benign or is it aggressive? If you've done that bit, you have crossed the pass line. Bone marrow edema, I'm sure everybody has heard Dr. Bochu say 1:3 ratio. If the lesion is 1 centimeter and you got bone marrow edema which is more than 3 centimeters or thrice the size, yeah, which usually means it is a benign lesion. It is could be trauma, and you got a whole list over here. If you got actually a lesion, is usually an osteoblastoma or a chondroblastoma if it is in the epiphysis. Remember, osteoblastoma usually occurs in the diaphysis or the metaphysis. If it's in the epiphysis, think of a chondroblastoma. If you have in a joint and you got lots of synovitis, you have to think of infection. Remember, in the back of your mind, always keep infection as a possible diagnosis in a child bone tumor. Yeah. The other caveat I would like to remember is, think of calcific tendinopathy, but this usually occurs in an adult patient. But if you see an excessive bone marrow edema and there's a lot of cortical, periosteal and adjacent soft tissue edema, look carefully, can you pick up a calcium? On an MRI, you may not pick up. If it is a very accessible area, like for example, the shoulder or the gluteal region, ultrasound is quite good at picking up calcium. You don't even need to do a plain film. Malignant pattern. If it's a malignant lesion, it does not have much bone marrow edema. Yeah. So if you look at just the stir sequence, you can see it is all pretty bright. But here, as I said, the T1 sequence is very important because a normal bone marrow contains fat. So where there is marrow replacement, yeah, you can see that very well on a T1. Of course, you can do T2 Dixon sequences to use fat, water, chemical shift imaging to differentiate between fat and water. But T1 weighted sequences usually give you a good grip on this. But of course, again, where's the diagnosis made? Not with the MRI. You cannot make a diagnosis on the MRI. The plain film clearly shows a bone-forming tumor, a periosteal reaction, Codman triangle, and you know straight away that this is an osteosarcoma. Fluid levels, everybody has spoken about it extensively today. Yeah, I am always very scared of calling a lesion with fluid levels as an ABC. Yeah, I take a pause and make sure that it is completely what you call thin. You got only fluid levels, nothing. Because what are the possible diagnoses? I've given you the primary and the secondary and the telangiectatic. You also got to do the brown tumor. So if you see any lesion in a child with fluid levels, do a bone profile, calcium, phosphate, and all those other things you got to do, the metabolic syndrome. And then I give contrast in a fluid level lesion to see if there is enhancing soft tissue mass. Yeah, sometimes you cannot pick it up because the whole thing looks like a sea of fluid levels. But if you give contrast and if there is a mass, you can see the enhancement. So this is one of the few times I actually give contrast, and I biopsy every ABC. You never leave an ABC on its own. You either treat it surgically, or you do sclerotherapy, or you give chemotherapy. You give denosumab to solidify the lesion, and of course you can then take it surgically. So you got to be a bit careful. So in this case, as you can see, there is a large lesion in the sacrum. In this case, I treated this patient with post doxycycline. You can see it's completely ossified, and she's very well. So another example of fluid levels, as you can see, this is slightly more heterogeneous than the previous one, and this was a telangiectatic osteosarcoma. But again, if you look at the plain film, you can see that this is an aggressive lesion. Therefore, you should be always cautious. To say, see fluid levels, don't jump and say ABC, take a pause. Another example here, again, seemed very heterogeneous, biopsied, and you can see it was a what you call very heterogeneous pattern of enhancement, but this turned out to be an ABC, because you can have ABC you can have a solid ABC as well. Therefore, you give contrast in these cases, biopsy the enhancing bit. Of course, if you're not a tumor center, don't biopsy, send it to a tumor center. So local staging, I've used osteosarcoma here in the axial plane. You can see what you call from the intramedullary cavity going out to the cortex, the periosteum, the soft tissues, and as it goes out, you want to see the relationship with the neurovascular bundle, because that's what you call is how the surgeon will decide on how he's going to operate and what he needs to do. Yeah, this is an excellent paper by Dr. Singh and his colleagues. You can take a picture of this and you can review it later. We also do a whole bone MRI where there's an aggressive lesion to identify a skip lesion, as I can pointed out on the top. Most of the lesion is in the lower diaphysis, but here in the proximal diaphysis you've got a skip lesions, quite common in osteosarcoma. Therefore, as I say, what the mind does not know, the eyes do not see. You need to, if you're going to be doing tumor work, you need to read very well, you need to be up to date with the imaging, and you need to look at the image searching, because I actively search, is there a lesion? And this could be an enchondroma or focal nodal hyperplasia. How do I differentiate it? I will probably do a diffusion weighted sequence, or I might even do a CT scan to differentiate whether this is an active lesion or not. And worst case, if it is still indeterminate, stick a needle into it. Because this will change from a distal femoral replacement to a massive, what you call, prosthesis of the entire femur. Growth plate considerations, and Dr. Chidambaram has spoken very well on the physis. Just this one slide on it. Lesions which cross the physis. Yeah, malignant lesions, of course, they do not respect boundaries, because early stage they will respect, but in the later stages they will go through. Then you got the benign aggressive lesion. Osteomyelitis again can cross the physeal plate, and chondroblastoma can also cross the physeal plate. Okay, just to show a couple of examples of local staging. Here, as you can see, the lesion is primarily in the metaphysis, but it's grown into the physis, gone into the joint, and you can see the soft tissue extent. And you also can see what you call a separate soft tissue lesion here, and you can see the skip lesion over here. This is an extreme example of an osteosarc. In this case of a whole body staging, well, we'll just skipping it. Example of a lymphoma. As you can see, there's a lesion in the previous one, and here we can see a lesion further up, and you can see the splenomegaly. So I speak a little bit on the soft tissue tumors. Most soft tissue tumors are benign. If it is a malignant lesion, most of them are rhabdomyosarcomas in a pediatric age group, and the other half is a non-rhabdomyosarcoma, and the commonest soft tissue sarcoma in a child will be, non-rhabdomyosarcoma will be a synovial sarcoma. Then you got a MPNST or infantile fibrosarcoma. The thumb rule, if you're seeing a soft tissue lesion, is greater than 5 centimeters, deep to fascia, and if it increases in size on serial imaging or on clinical examination. What is the role of MRI in soft tissue tumors is, one, detection. Characterization is very poor, and most soft tissue lesions, if it looks aggressive, you're going to stick a needle into it. This is another lovely paper by D.K. Singh, MSS member. So there's no way I can make a diagnosis. So this helps me detect a lesion, and then I got to do a biopsy. And this is an example of a rhabdomyosarcoma. I mean, somebody would have said, this is a neurogenic tumor, you can see the expansion, this and that. Rubbish, yeah? You're seeing a lesion, needs a biopsy, do it. Some cases it is useful. As you can see, this is lymphatic malformation. There is not much, but I show you two cases, one on the top, one on the bottom, and you can see there is absolutely no, what you call, characteristic features. One is a tenosynovial giant cell tumor in a soft tissue. Second is a nodular fasciitis. Yeah. So there is no way I'm going to make a diagnosis on lesion characterization on an MRI. I need to do a biopsy. Another one. What do you guys think? Yeah, this could be an epidermolysis, or somebody who has got a sebaceous cyst and got traumatized. Soft tissue Ewing sarcoma. Therefore, a mass in a child approach with care. Yeah. Whole body MRI, again, they say doesn't, in this case, angiomatoid fibrocystoma, they say doesn't metastasize, but this can metastasize. There's a lesion in the forearm, there's a lesion in the arm, and there's lesions in the axilla. I'm nearly done. My tumor protocol for bone tumor is this. And my soft tissue tumor protocol is this, which is also exactly the same. Yeah, not much difference. I would add a diffusion weighted sequences in it. Okay, come to the end of my talk. Thank you very much.
Thank you, Dr. Kumar, for an excellent overview of pediatric and MSK tumors. Not feasible to do complete justice, but I think he's done a great job. Please give him a great round of applause. And thanks to all the speakers for sitting here. Over to the organizers. Both the rooms are going to be merged for the quiz. That was the reason we were to stick to that.
Next month, next year.